this day by our friend and colleague, Professor Dr. Azzam. He was one of the well-known name in Egypt and Middle East and in all over the world in many effective topics, and it is very effective for us in LRS to have his experience every now and then. And I also acknowledge his share this day because he have a lot of knowledge, which is actually in relation with LRS. LRS,
صوت
هو المفروض النت فصل بس الدكتور فاضل.
شكرا. النت فصل عند حضرتك يا دكتور فاضل. أيوة unmute yourself يا دكتور فاضل.
the internet started our day by this interruption, but as we know all, LRS continue whatever the condition. We can continue by Fadel, by Professor Amr, by even in any condition of emergency. You will see our colleagues that we have a moderator and a sub-moderator also, or a co-moderator. The moderator of this day, who of our colleagues would like to be a moderator of the trainee? Do we have one volunteer to be a trainee of a moderator for this day? So, Dr. Who will start? Okay, Dr. Azzam from Sudan, he will be the moderator. And if something happened interrupted, Dr. Sabah from Iraq will be the co-moderator. And if any interruption, one of those will continue instead of me. And now I find our friend Dr. Shamsul Hoda also associated us. It is very nice to be with us early in this time. And let me introduce for you our friend Professor Azzam, Dr. Shamsul Hoda, co-moderator, and also the moderator and the designer of this collaboration with India, ASAMI, and also TV. Thank you, Dr. Shamsul Hoda. Just 1 minute or 2 minutes for as introduction for our colleagues, and then we'll present to Professor Amr to present his talk.
Thank you, sir. Thanks a lot, sir.
Welcome.
I really feel glad to be on this gracious platform. I really thanks Fadel sir and Amar Azzam sir for being here. I'm
nice
representing. Hello, sir.
Hello. Nice meeting you. Thank you.
I'm representing as a Joint Secretary ASAMI India and coordinator of Ortho TV here. So this is going to be our first program of LRS.PD and ASAMI India, and we really want to do much more in the near future. Today we also have our Ortho TV coordinator, Dr. Ashok Swami over here. Ashok, are you here?
Okay.
So he'll be making live. He's the chief of Ortho TV.
Okay.
Thank you, sir. Thanks a lot for meeting me here, sir.
Thank you. Thank you, Dr. Shamsul Hoda, for this welcome word. And I would like to present my dear. Do you need something to say again, Professor Dr. Shamsul Hoda? It's okay?
Yes, it's okay, sir.
Okay. May I present for you this nice morning Professor Dr. Amr Azzam for presenting some of his excellent lectures up to date and in touch of the daily working activity of most of our residents and specialists in orthopedic trauma. Professor Amr, you can start, inshallah.
Thank you, Professor Fadel. Nice meeting all of you in a very nice morning, Friday. Let's start first. My name is Amr Azzam. I am in the National Institute of Neuromotor System, the unique institute here in Egypt, in Cairo. I am an AO Trauma Regional Faculty, and also I was the chairperson of the AO Basic course a few days ago here in Egypt after stoppage of about 2 years. Let me start with the first topic, why we are going to speak about implant removal. I believe deeply in my heart, this is a very important topic to all orthopedic surgeons because we are facing this in our daily work, on daily practice, facing many problems all through our lives. Shall we start? I have no potential conflicts of interests. About these learning outcomes, to explain.
Excuse me to share the screen.
Okay, thank you. Okay. Is it seen now?
Yes, good. From the
Yes.
start. Yes.
Thank you.
Very good.
About these learning outcomes, to speak about such an important topic, to explain what is indicated and contraindicated for this method removal, and also the timing for the proper removal of each implant, to discuss with the patients and also to discuss the doctor's expectations from such a problem that may happen during our implant removal regarding the complications and the patient consent, which is a very important topic. The patient follow-up after removal, a very demanding procedure, and also the patient wishes and risks for this related to our removal. About our historical review, the first to mention about the Sir William Ram. He's started in the metal bone plates in 1907. I think it's about 1,000 or more than 1,000 years ago. It's can we define it? Yes, we can. We have to see that the implant is a material that is interested or grafted into the intact tissue or body cavity with a specific purpose. We may use either the metallic implants or non-metallic implants. Metallic implants might be iron-based or the titanium-based, the most inert one, or cobalt-based. Non-metallic may be, as you all know, this polymethyl methacrylate or polyethylene or silicon as well. So what are our indications for this removal? We have to see that this gross disturbance in the pediatric population is a very important topic. Also, the non-union of such an implant. The result of implant failure, as a result of implant failure, we have to remove it. The soft tissue also irritated might be as a skin, nerve, or tendon. Regarding the infection, was a very important and very large topic, and allergic reaction was seldomly seen except with titanium, and also in the sports patients in a very special consideration for this sports population. What is the elective removal? We are after complete consolidation and remodeling of this medullary canal regarding the intramedullary nails, we have to confirm the fracture healing is happening and evaluating the type, condition, and also the location of the implant preparing for our removal. So we have to ensure the correct implant removal equipments to be inside the OR. Regarding the removal, it might be an early or late. An early after achieving the goal, especially if there's a syndesmotic screw in the ankle, so it's not related to the healing of the fractured ankle, and we have a lot of debate about this topic. So the screws or tension bands might be removed during due to skin irritation in the elbow, and late removal also might happen in the young patients around the patellae or around the malleoli due to skin irritation as well. Here we have the example for the removal of syndesmotic screw after healing. We all know that we have so many literatures talking about this removal of this one, and so many or recent one not in favor with the removal. Also, the irritation of the skin by implant in the elbow during the olecraneal fracture due to these sharp edges of the tension band. Also, we can see here the subcutaneous clavicular plate that has to be removed after complete union of the fracture. Also, in cases of non-union, as this DHS is non-functioning now, so we have to remove it. Also, the proximal femoral nail, whatever the type is, the commonest site for the implant failure here in the proximal part, and here has to be removed and properly managed. Regarding the soft tissue, also we have the rupture of the flexor pollicis longus. It's commonest tendon to be ruptured due to a prominent plate in the polar aspect of the radius in the lower radial fractures. Regarding the infections, we have three types or three parts: the infected plate, infected nail, or fixator. Okay, what about the infected plate? We have to divide it into acute and subacute or late. The acute, after 2 weeks of surgery, we have what we can do for this. We have to do an open acute debridement, microbiological culture from the 4 quadrants of the wound, and appropriate antibiotics intake, and we have to judge intraoperatively the stability for this implant. So if it is stable, please leave it in place. If we are going to remove it because of its loose or interfere with adequate debridement, we have to remove it and replace it by fixator, whatever the type is. Delayed representation from 2 to 6 weeks is a hidden infection. So what we are going to do, also we are going to do an open debridement, antibiotics for 2 months or more if the hardware is not loose, and if it is loose, then the same, we have to remove and do an external fixator. Please don't be late. Whenever infection, you have to act fast and sharp. What about the removal of due to infected plate in cases of chronic infection? It would be more than 10 weeks. So usually in the diabetics or the immunodeficient patients, we have to do a diabetic diabetes control and surgical debridement, either the sinus tract excision, what we can see, or remove all the hardware, and please bridge and irrigate the medullary canal in case of intramedullary nails. Here are our examples. This is an acute infection after 2 weeks post-operative, angry wound. Don't leave it as it is and give just antibiotics. Please, you have to interfere with this situation. And late presentation also of infected hardware and exposed hardware from the skin as well. Also, this is a delayed presentation of the tibial plateau fracture, fixed 6 weeks post-fixation with a lateral tibial plateau plate. And here we have to remove the hardware and then putting the debridement and suction irrigation. What about meta removal due to IM nail? It's the same principle. Adequate debridement requiring removal of the nail and reaming of the Darley canal. Reaming of the Darley canal is considered as also debridement. This is a very nice tool to debride with. Also, the distal opening is so to act as a vent to allow for debris to escape from the medullary canal, and the canal is thoroughly indicated by a continuous suction irrigation system. Also, to apply a fixator if it's not healed the fracture or the infection is early due to less virulent bacterium, so renailing might be considered with a special considerations. Regarding the late infection or resistant organism, placement of the antibiotic polymethyl penicillate nail, this is an old technique or an X-fix. We have an old one and recent one. This is the suction irrigation and distal fenestration of this femur to allow for all debris to get out. And here is an old technique for the polymethyl methacrylate coated rush pen and to be inserted inside the medullary canal for temporary indications. And this is a recent one. This is a tibial nail with gentamicin, a sulfate coating with just seen in the AO census 2011, about 10 years ago, but it's a very expensive one, and it is inserted properly in its situation only. Okay, let's have a look on our institute. Here we have the National Institute of Neuromotor System in Cairo, Egypt, beside the River Nile. What about the metal removal due to infected external fixator? The very easy one, the simplest one. Should we remove the pin and put another one beside it? So it's very easy to be done. Or the pin side debridement by hard drilling, by the hand drill, and or a curette or something like that. And also you may replace this side by another side. Or removal is rarely required for all the fixator. As you all know, we remove only the infected one. What about the other indications when this additional surgery is required? Other lysis. The three lysis are the arthrolysis due to stiffness beside the joint, or tenolysis due to impingement around the lower radius or the elbow, or neurolysis might be needed for the nerve irritation either by callus or screw or plate. So these are the three conditions that we have to remove the hardware as an additional surgery. What are our relative contraindications? As you all know, in the elderly patients with the osteoporosis, this is a high risk of the refracture around the screw holes, so or the original condition that is not favorable for operation, and the local circulatory disturbance as well regarding the diabetes or peripheral arterial disease, that this wound or the surgical wound for the removal would be a problem. Also, the areas of high risk iatrogenic neurovascular damage is calculated in the literature in the forearm in the three parts: the forearm, humerus, or the pelvis. Also, the immunodeficient patients, it's wise not to interfere with the removal of the hardware in case of hepatitis or HIV or TB. Also, this is a very important slide about the surgeon-related concerns for removal. We are all concerned about minimally invasive in the maximal, or it will be a maximally invasive. We have to do a large incision to remove our hardware. Also, depending on the OR time, it will be increased, and also the cost. Other modern material can be difficult to be removed, as you all know, the LCPs, locking compression plates with difficulties, as the screw head is screwed inside the plate. Intraoperative or post-operative complications in the wound or in the patient. The surgeon frustration to fail or failure to accomplish this surgery. It seems to be easy, but you may fail. So it will resulting in a broken implant or retrieval of the equipment also will be difficult, and a prolonged surgical time causing the frustration of our surgeons. So this patient-related, we have here the very important, the patient is subjected to another operation and a new period of rehabilitation after removal of the screws and one with bearing and something like that, and larger and more unpleasant scar with more fibrosis around it. Complications may not disappear as regarding the pain or the stiffness, and the complications with temporary or permanent effects might happen around the joints especially. When we review our literatures, there is no clear data in literature regarding the routine removal of the implants, especially in pediatric implants. But we believe that the German surgeons believes a lot about the removal of the hardware. On the other hand, the implant left in the growing child might be buried inside, and the periprosthetic fractures which happen can impede the adult reconstruction procedure. So the young generations or a young age, we have to remove the implants much, much more than in adults. We have a very little or clinical or experimental evidence to support the policy of routine removal of asymptomatic implants. This is CAL 2007 or 2007, or the doctor's concern regarding the stress shielding, risk of corrosion and metal allergy, and potential carcinogenesis with a very rare situation, was published only in one literature in the International Orthopedics 2010. Please, this is the goal of our talk today. Be prepared, know what happened. You have to take a very good history, know the limb examination, and know the implant which is placed and who did it, and have all the right equipments. Please be expecting the unexpected. And my advice is, you may remove the hardware only that you have inserted inside your patients. This is a very safe situation for all of us. What about the timing of removal? And this is a very important slide talking about the plate removal. It's published in the AO Trauma 3 years ago. Regarding the plate removal, we have the consensus that the more than 24 months in adults regarding the medullary canal to be restored, and more than 6 months in children less than 18 years old. Also, the plate removal in the cancellous bone metaphysis may be more than 6 months. My talk is about more than 6 months, so it might be 10, 12, whatever you like, but not less than 6 months. The IM nail, it might be more than 18 to 24 months in adults, and removal also of the nail more than 6 to 12 months in children. This is a rough estimate for all removals. Regarding the preparation, you have here, you may face a situation like stripped head, broken heads, stripped heads, syndesmotic screw, or difficult implant here to be removed in the LCPs. What about our tools? This is an AO set, screw removal set, and it's a very expensive one, and you may have it in your hospital. It's a very achievable goal to have such equipment. Also, you have another companies having the same, but in an informal way. This is a screw removal set, about it to be about 48 instruments inside these racks. What about our mobilization after surgery? This is very important to speak about the weight bearing and permission to perform the strenuous activity. So this, we have our goal to allow the patient for early mobilization. So the intramedullary nail, consolidated fractures, or you may let the patient weight bear early, but if the patient is having the fixation by plate and the plate is removed, so advise him not to bear weight for 4 to 6 weeks until you see the callus formation inside the plate holes. The follow-up is very important to follow the patient. Don't leave your patient. Please, regular follow-up for him to be done. General condition of the patient to be spoken about, local examination of this removal, and x-rays. So the patient should be asked to review back immediately if he experienced pain or another injury or any other related complaints. Immediately refer to you again. To summarize our talk today, this implant removal is a complex procedure, as the bone remodeling around the implant may make the removal difficult or maybe impossible. So please, in your consent, please let the patient to have a consent that is its probability or the trial of removal. This is not an operation for implant removal. This is an operation for trial of implant removal. بالعربي محاولة رفع الشريحة, not رفع الشريحة. The patient is exposed to the risk of neurovascular injury, refracture, and complications of anesthesia, and also the cost of the procedure that might be lengthy. Therefore, it should not be taken lightly. Don't leave it at the end of your list. A deep thought should be given to the benefits and drawbacks before advising the patient to undergo this procedure. You have to speak thoroughly with the patient and his family about all your concerns. And it should not be treated as a routine procedure. We have the last word. The implant removal starts at implantation. So prepare yourself while you are implanting something that the days will turn over on you, and the days will come after a while that you have to remove your implant again. Here are my contacts. This is my email, the Facebook page, and also the Pablon Researcher ID. Let's to speak about the very nice part of our talk today, as we have the virtual or the online lecture. So let's speak about the screw removal factors. Here we have the recesses inside the hexagonal screw head as a regular screw, and recesses, these hexagonal recesses inside the locking screws as well. The hexagonal, this is an old form, the star drive, the new form, and the very old one, the form. Each one of them have a special screwdriver. What about the screw removal techniques? We have given to you, or we have starting to with you small videos to show you this how can we do it. To do such a case, assure that the screw head recess is clear out of soft tissue. You have to insert a very sharp instrument or hook to remove the soft tissue or callus inside the screw heads before doing anything. This is a very golden step in our removal. So please, you have to insert this screwdriver inside the screw head properly. This is not fully engaged, and this is an oblique engagement. It wouldn't be right in your removal. So you have to do it like that. You have to engage the screwdriver head fully inside the hexagonal or whatever the screw head is. Here you have also, this is the right way, this is an improper engagement, and this is an oblique. You have to be in the direction of the screw as well. Failure to perform it, you are going to strip your screwdriver recesses. What about the stripped screw? This is the head is stripped from its part, the head part. So the recess around may be deformed, and we have to drill inside. This is a drill pit. This is a metal drill pit with a tremendous heat. And it's apply the conical extraction bolt, as we are going to see after a few seconds. We have to drill here. So this metal drill pit is especially used inside the difficult implant removal set, generating a tremendous heat. So we have to do a cooling effect, protecting the soft tissue and bone around it. Taking into consideration that all instruments inside the difficult implant removal set acts in the anti-clockwise manner or direction, except the drill pits. The drill pits, these metal drill pits in the clockwise direction. So the strip screws we have to do after drilling inside the screw head, we have to do what we call it conical extraction bolt, and this is a conical extraction. It might be having 3 or 4 shapes with the different threads for the cancellous, cortical, and the large screw and small screw. You have to try it all until you engage this conical extraction inside the strip screw head. Here we have our first video to talk about the conical extraction bolt. Now we are removing it. In a real life scenario, it's not easy like that. This is another video to show you how can we do it. screwdriver is not working, so the head is trapped. So we have to try the conical extraction bolt in the three forms of conical extraction bolt of each screw size until it engages in the anti-clockwise. You can see here anti-clockwise direction, and then it goes, the screws goes out. So what about the broken screw? The broken screw head, we have two types of broken screw head. Either the shaft is visible from the edge of the bone or non-visible. For the first situation, what about the visible one? So we have to drill the screw head off and protect the soft tissue with irrigation and collect the debris, and then the screw head is removed or it's broken from the start. So we have to remove the plate from the surface of the bone and then to deal with the shaft. So first you have to dig around it by the gouge, and then to hold it with two or three modalities of pliers. Also, under using the gouge, open the cortex around it all through. We are going to show it in the video, and this is a special plier. This is a locked plier to engage in this shaft and then go anti-clockwise direction for removal. Here we have the video for it. The gouge first widen this area around the screw shaft to be seen more. And then with the special pliers, we have one of these pliers here, holding the screw shaft with the anti-clockwise direction to remove it. Also, the pliers we are talking about, the special plier for removal of the shaft only. Don't use it for removal of the screw heads, please. It's not made for the screw head removal or the screw head unscrewing or removal. Have a special threads inside this plier designed for holding the shaft of the screw properly. What about the broken shaft inside the bone, which is not visible? Here we have the deep part of the screw shaft embedded inside the bone. So we have to use this instrument. This is a hollow reamer, and the working anti-clockwise to ream around this, the opening of the shaft, go inside this shaft and goes out with it, anti-clockwise direction as well. Or we may drill around it by the hollow reamer and it's not removed, so we have to use the next one, which we call it the extraction bolt, working in the anti-clockwise direction. It engages inside the broken shaft inside the bone in the anti-clockwise and goes out in the same direction as you are going to see here. Broken head, it happened in the workshop. The shaft is inside the bone. Gouge is used to widen the area around, which is not seen, so we have to use the hollow reamer. Hollow reamer is used by hand, not on a drill bit, not on a drill. Please don't use it by your hand. A very difficult one, but you have to do it by hand to feel the direction of this shaft inside the bone. It's not an easy procedure. The hollow reamer and removing the debris by a special hook inside the implant removal set. Conical extraction bolt is now used. It threads anti-clockwise direction to engage the embedded shaft inside the bone. You have to use some force to insert it to engage the broken shaft part of the screw. This is the wrong direction, and then this is the right direction, counterclockwise. You can see the conical extraction bolt is removing or engaging the shaft, screw broken inside the bone and going out, like anti-clockwise direction. We have another tips or tricks that might be used. If you have the high-speed burr, you may break the plate around the screw which is jammed, and also you may cut the plate proximal and distal to the jammed screw and use the remaining of the plate as rotational or the screwdriver to rotate it counterclockwise to remove it. But it's seldomly used as we don't have the high-speed burr for the plate in our hospitals in the routine way. This is a very nice technique. I like to have to you all to have it. When we have a combi hole inside the locking LCP plate, locking compression plate, the screw here is inserted in the locked manner, and the widest part of the plate hole is empty. So you start by drilling the bone by regular drill bit, just beside the screw jammed inside the locking or the combi hole in the locking plate or locked plate. So you have two holes, hole inserted into the screw and a new hole, the bicortical hole, just posterior or beside it. Use a special or the impactor or something like that to push the plate and the screw to go inside this hole by very gentle hammer blows. And here you can see that the screw jammed inside the plate might be removed, all of them, the plate and the screw in the same unit. Here, this outcome, this first you have drilled, and this is the hole that the screwdriver or the screw was inside the bone. So when you are hammering in this direction, the breaking the bar or the septum between the two holes and removing the screw with its plate in the one unit. This is the last for our tips and tricks to remove our difficult implant removal, especially the plates. Also, we have a very nice talk about difficult implant removal regarding the IM nail, which we are going to talk about later on in our meetings. Thank you all for listening.
Thank you so much, Professor Amr, for this comprehensive lecture. As a rule in our teaching and training program in LRS, we can permit for or have a permission for few questions, not exceeding the limits. And if we have more extensive need for more discussion, we can leave this for the late of the program. So we can accept from you, our dear viewers and dear attendees, trainee or others, to just start talking for Professor Amr directly. عايز يسأل منكم يا شباب يسأل مباشرة مع دكتور عمرو مباشرة، يدوس على المايك يفتح
يعمل unmute ويتكلم. تمام.
Okay, may I ask the famous question that I know that they will ask you later, that from where here as an Egyptian field, may I ask Professor Amr to give me advice from which company? I think that you can refer this message for special contact. Yes, but yes. I think that you can guide us for the companies concerning with these difficult tools. I think this.
Yes, as you know, Professor Fadel, we have here in Egypt now 3 companies having such a difficult implant removal. and the fourth is the census company branch in Egypt, and it is available now in a very reasonable price.
Good, very nice. Good.
I think this the 40 or the 50 instruments inside each box worth its price.
Yes.
Once you use it, or per month or per year, it worth its price.
Right.
We spend a lot of time removing one screw and get frustrated and asking for the help of our colleagues, and they get sterile and then come with us, and also we can fail for more than 1 or 2 hours.
Actually, you are right. Actually, you are right. I am very happy that now we have not one or two companies, but 3, and all their use are. I think it could be hired.
Yes,
and
thank
for
you.
good institutions or available financially, they can buy it. I think it is a good advice to buy it.
Yes, but borrowing or to borrow such an implant or the set with a very cheap money, you may spend it and let it to be beside you, and if you're not going to use it, the God likes your work.
Very good. Excellent. Thank you so much, and it is a chance to shift for the next lecture. Thank you for the first one, and we are waiting you for another one of your excellent presentation.
Okay, thank you. May I reply to the chat box? I have
yes,
here.
If you have some questions, yes.
One question here: if it is safe to use a diathermy as a heating tool to loosen the bone around the shaft of the broken screw, it is not written in any literature whatsoever to use such a diathermy to loosen the bone. The bone will not loose. This is a very nice question. First time to see it. So this is a very important knowledge to be done or to be known, that you have not to use the diathermy as an implant removal to loosen the bone around the screws.
At least if you heat something, it will increase inside.
Yes.
Increase inside. If you are trying to make a necrosis in the bone, it is worth more bad effect for the bone later. You may cause osteomyelitis.
Yes.
In both sides, it is a double sword effect of bad results.
And if you have done, if we have done such a procedure for the near cortex, what about the far cortex? How can you reach the diathermy for the far cortex? It's not used whatsoever.
A good question. It is very nice. Any more questions? He asked about another one. Ahmed Kamal Musalhi talk about Dr. Magda Andraus. Thank you for your attendance with us and for this very good questions. Thank you so much. Dr. Magdi have a very nice group in the WhatsApp and usually follow up many things of beneficial tips and tricks for our colleagues. Thank you, Dr. Magdi. Dr. Ahmed Kamal asked if it is infection. He talked that the question is maybe related for the infection one. Anyhow, the question had been answered fully by Professor Amr. Thank you, Professor Amr, and I think that we can shift for the second lecture.
Okay, let us to have a very light one to speak about the case presentation, to be let it to be an interactive, yes, to make us to interact with our dear participants.
If it need to be stop share and reshare again by the new one.
Okay.
I think.
Is it seen now?
Yes.
Yes.
Paralytic relapsed?
Yes.
Okay, you are right.
Here we have our patient. Is a female patient with a 6 years old meningomyelocele. This is a problem inside the lower back, the complete paralysis and sensory loss below L4. And previously have done the Achilles tendon lengthening surgery 2 years ago. Here we have this young girl walking like that. This is a standing views from the front and from the back. A very awkward situation to walk with. This is a scar for the meningomyelocele have done in her early life. And also from the AP view, how can we describe such a deformity? This is what we call it talipes equinovarus. Someone can call it a congenital talipes equinovarus. This is a non-congenital. This is a paralytic type. Okay, this is a lateral view. It's partially corrected. And also from the side, this is a pressure source on the lateral aspect of the foot. And this X-rays to complete the examination and investigation. This is the meningomyelocele and widened deformed lower back, lower lumbar vertebrae. Regarding the X-rays, you have an equinus deformity and virus. This is a video for it. She's walking with difficulty. This is not an easy type of walking. She's walking on her knees, but she's walking now in front of our camera to show us how can she walk. So the question is for you all. What can we do for her? Can we leave her like that, or can we do something for her? Okay.
It is interactive, dear colleagues. I think that you can share.
Yes, please.
I have no idea how to do approach for this case, or you are a little bit shy to face this condition.
Let me to break the ice with them to speak about. A few years ago, when I was outside the institute that I'm in now, when I may see such a case, I may go away from it. The very awkward, difficult situation. How can we analyze? This is a very important subject to get the proper decision for her. So, what about to analyze such a case? This is the deformity in the midfoot and hind foot, cavus and adduction in the midfoot, varus and equinus in the hind foot. So we started to manipulate her as a Ponseti technique. As you all know, in such a congenital talipes equinovarus, it's worse than to use it in such a paralytic talipes equinovarus. So we started to correct after 3 consecutive casts, well-padded casts. We had corrected cavus, adduction, but mild varus and equinus, it didn't yield or didn't correct. So we have to work on this residual. What can we do for her? This is an equinus due to the room for the talus is very, very, very small to move between the lower tibia and the calcaneus. When you analyze such a deformity, we may think about surgical correction. Anyone to answer? No? Okay. Can we proceed?
We can.
So, okay. Fadel.
We can do for the equinus Achilles tendon lengthening or tenotomy.
Thank you. Is it all the problem? This we have virus, and we have such a relapse from the Achilles tendon 2 years ago. When we are going to do an Achilles tendon alone, the relapse is expected.
Yes, for the virus, we can do also post-remedial release and correction.
Okay. Any other ideas?
Thank you, Dr. Mosheer. I hope that any of you, dear colleagues, to say or to mention your name, please, first. Dr. Mosheer Ziadi from Saudi Arabia. Thank you, Dr. Mosheer.
Thank you, Dr. Mosheer. Any other suggestions? Okay, after thorough examination and radiology, we decided to have the Achilles tendon, like Dr. Mosheer said, Z-plasty, Achilles tendon Z-plasty, and posterolateral incision of the Norris-Carroll technique to do the Achilles tendon as well as the tight posterior capsule of the ankle and the subtalar as well, to allow for the room of the body of the talus between the lower tibia and the calcaneus to allow for backing back or going back of the body of the talus for proper biomechanical action inside the ankle. So we have to also, during this procedure, to cut the tibiofibular or calcaneofibular ligament to widen this space, and then to do a very well padded above knee cast until the Achilles tendon heals. And you may see such a correction in the equinus and varus on table after such a procedure. This is standing view after, I think, 6 or 8 weeks after the operation. It was a bilateral one. And here we have to the side view. She's plantigrade foot now. She's having such a plantigrade foot. We can see here the room for the body of the talus is becoming very wide to adapt for the body of the talus to go back inside the mortise between the lower tibia and the calcaneal articular surface. AP view is a corrected one, and here we have to use such a splint to prevent the recurrence of such a deformity. The splint is worn inside the shoes. Okay. This is her type of walking now. When to use such a procedure? Please use it when you have a good extensor mechanism of the knee. So any lesion for the meningomyelocele above L4, you may not use it, as the patient wouldn't have a extensor mechanism working properly and gluteus. This is a video from the back. So now this patient can depend on herself to walk up in a plantigrade way, assisted by a walker or crutches or something like that. And the physiotherapy is a very important role in such cases to increase the muscle power around the knee. What are the key points for this case? It is never too late. You wouldn't leave this patient to live like that. You have to do a proper assessment, EMG, and also close pre-operative and post-operative follow-up. Please don't leave her. And with a proper splinting that you may change it after after few months as the patient grow. And a very important physiotherapy, you have to work with a physiotherapy as a team to help such a patient. Thank you. This is our first case presentation.
Thank you, Professor Amr. May I mention some comments had been written on the chat until you unshare and prepare
Yes.
the share
Yes.
for the next one.
Yes.
Here I would like to thank Professor Ahmed Nahla, who associated us. Professor Ahmed Nahla, orthopedic and trauma and the limb reconstructive surgeon and pediatric surgeon in Zagazig University, orthopedic department. Hello, Dr. Ahmed. Welcome. Kul sana wa tayyib. He suggests that telectomy also may be used. Another suggestion from Mohamed Abdel Alim also ask for tenotomy. This is one part that you mentioned. And another Mohamed Abdel Alim asked that tenotomy plus arthrodesis. I think Dr. Amro can say something about arthrodesis this age.
Yes, thank you, Professor Mohamed. Telectomy, thank you for the
Mohamed
suggestion.
Abdel Alim, Mohamed Abdel Alim, he suspects that he can do arthrodesis.
Thank you. This arthrodesis for such an age, it's not used whatsoever. Let her to live her life properly. If you have a solution for her to maintain the range of motion around the ankle and subtalar, please do it. Don't stop all the mechanics around the ankle as the patient is paralytic.
Another comment from Dr. Magdi Andraus said that the patient to do a complete extension of the knee for the patient, do you need to do supracondylar extension osteotomy?
Okay, thank you, Dr. Magdi. As I have shown you in the photos about the case, that the patient is having a very good full extension knee. I didn't talk about it. I left it to you to see it. When you have such a condition with a limited extension, you may do a supracondylar as well. But here in such a case with a full extended knee, it is a great success for us to tackle only the subtalar and the ankle for this procedure.
Thank you so much. This is a very nice comment and also a very good comment. Thanks to Professor Ahmed Nahla. He say for you Kul sana wa tayyib, and he tried to talk with you, but the microphone is not working well. Thank you, Dr. Ahmed. You can unmute and talk at any time, Professor Ahmed. Anytime. Okay, Dr. Amr, we can start.
Can we start with our interactive case presentation now? So be prepared, all of you. We are going to draw on our screens, if you can do. We are going to draw the solution of these such cases of deformity. I think it would be an interactive one. Dr. Fadel, this presentation was done 2013 in collaboration with you, Professor Fadel. I kept the cover screen as it is.
Yes.
To show them that we are working so many years ago, helping how all of the participants, how to design, how to plan for the correction.
Yes, you are right.
Yes, Dr. George Fuad prepared this presentation and reviewed it for it. I was a reviewer, and it was very nice one. I found it on my laptop, and he was astonished himself that I kept having it so many years.
And we are lucky to watch it again. May I ask Mr. Abdurrahman, the IT supporter, Dr. Mr. Abdurrahman, can you open the chance for our colleagues to draw? Mr. Abdurrahman, ممكن تفتح للكل إنه ممكن يساهموا إن هم يرسموا على الشاشة.
Yes, doctor, it's open now.
It's very nice. Please, can you tell them how they do this? In Arabic, in a rapid way.
Okay, if you use the mobile application or mobile view, you can find annotation in the down left, and if you use the laptop, you can find it in the top of screen, view options, and click annotate.
Okay, so options and to check and choose.
Yes, from desktop view.
أيوة.
the top of the screen, click view options, and then annotate.
Okay, all of you, I think it is easy then to choose the pen.
Yes.
Yes. Okay. I think we are ready now. It's okay, dear colleagues. Okay.
I started yesterday to have my training with my daughter. I opened the Zoom meeting and we started our Zoom meeting yesterday to use all the possible drawing tools in this annotation. It was amazing. So please, on your desktop, you may click on the annotation bar, annotation icon, and then you will see the annotation bar. You will have to click on the left side, the mouse. Yes, Asim, I've used it. Thank you. And click on the mouse. Then to go to the draw icon, click for the line, and then to start your line drawing. When you click on the arrow, you may draw an arrow. Can you see it all?
Yes.
Okay, thank you. Let us to enjoy it.
Yes,
okay.
Good. Ahmed Kamal also, very nice, good.
Ahmed awesome. Hey.
Yes. Okay.
So I will stop share now because I'm having something, and then we'll share again. Mm-hmm. I think the presentation is jammed. It's not working.
You can stop share and start it again. Yes.
Start it again. Yes. I will share it now. Is it seen now? Can we all see the presentation?
Yes, Doctor, it's seen.
Yes. Can we start with the two axes in the coronal plane, the mechanical axis and the anatomical axis? Is a very short review about these axes. The mechanical axis starts from the center of the hip to the center of the ankle, which passes in the center of the knee, and is having the joint orientation line, the proximal femur, having a joint orientation line, the distal femur, and also joint orientation line of the proximal tibia, joint orientation line of the distal tibia. What is the definition of the line? It's the distance or the connection between 2 points. And also, what is the definition of the angle? It is the relation between 2 lines. You have to remember all about these definitions. So the proximal angle here is made by the joint orientation line and the mechanical axis line, which we can call it, which is mechanical, starts by letter M. This is mechanical lateral proximal femoral angle. It's about to be 90 degrees, and so and so. You don't have to keep in mind these numbers. You may have it in your pocket or on the drawing inside your clinic. So it's not worthy to keep it in mind. But whenever you do it so many times and do the planning, you are going to remember it well. Also, the anatomical axis is a mid-diaphyseal point or mid-diaphyseal line of the femur, and it starts on the tip of the greater canter and also goes to the center of the knee. Here we have the tibia. Tibial mechanical axis and anatomical axis are almost the same. Between this mechanical axis line and anatomical axis line of the femur, we are having 7 degrees between them, 7 degrees angle. This is a modified sagittal plane or sagittal axis from the center of the femur in the lateral view to the center of the ankle, passing through the lower or the knee. And here we have a special consideration. This is a joint orientation line of the distal femur and joint orientation line of the proximal tibia. You have to read about it to have it thoroughly in your examination and follow-up. Also, these are the golden steps for deformity planning. This is what we call it MAP, the ABC. MAP means M-A-P. M for the measure, the mechanical axis deviation, what we call it the MAD deviation, and A, the analyze the joint line, and P is a pick the deformed bone, either the tibia or the femur. The ABC means A stands for the apex of the deformity that you have to denote where is the apex of your deformity. B denoting or aiming at the bone cut. Where can you do the bone cut at the level of the deformity or just away from it? You have to choose your level of osteotomy and you have to draw your correction. You have to start your planning on the scanogram. What are the rules for our scanogram to have the draw for it? You have to have the standing scanogram from the ilium, the uppermost part of the ilium, to the lowermost part of the foot. And the patient has to be standing with no flexion deformities whatsoever. If he is having a flexion deformity, it wouldn't be a standing scanogram. And also the patella have to be facing forwards. This is the rules for the scanogram. Let's start our first exercise. What about this case? To have the 6 steps, can we draw the mechanical axis deviation, which means that this line from the center of the hip to the center of the ankle, where will it pass? Medial to the knee, or inside the knee, or outside to the lateral side? Who can draw it now? Can we start annotation? Dr. Asim, Ahmed Kamal will start. Okay. Please do. From the center of the hip to the center of the ankle. You are drawing by your hand, not with a mouse. Okay, thank you. This is very nice one. So the mechanical axis deviation is the distance between this line and the center of the knee. We can now measure it. Okay, thank you. I may clear your drawing now to see what's going to happen. Okay, I will stop share and reshare again. Yes, this is a proper way that you have drawn this from the center of the hip to the center of the ankle, and then we can now measure the mechanical axis deviation. This is a distance between the center of the knee to this line. It's medial or lateral. It's medial, denoting this we have a genovirum, and this is mechanical axis deviation. First step is about to be 16 millimeter. What's next to be done? Map, measure, okay, the mechanical axis deviation, analyze the deformity. We can analyze now by drawing a line for each bone. The line for the femur will be from the center of the head to the center of the knee. And we have to draw also the joint orientation line of the distal femur from the lowermost part of the medial femoral condyle to the lowermost part of the lateral femoral condyle. We have to do a transverse line to make an angle with the line coming from the center of the head to the center of the knee. Can you help me to do it? Okay. Enable annotation. We are enabling annotation now. Who can help us to do it? Okay.
Good.
Okay. Let's to have one participant, not two. One only to have to be focused on his drawing. So he's drawing now the joint orientation line from the center of the hip to the tip of the greater trochanter. This is the proximal orientation line of the femur. And another one from the center to the center. What about the orientation line of the distal femur? Can we draw it? Yes, Dr. Mosheer. Now we are going to have Dr. Mohamed, please let Dr. Mosheer to help us, please. Thank you. Now we are having this joint orientation line of the proximal femur and distal femur. What about the angles? The angle between this line and the angle between the horizontal line. This is a lateral distal femoral angle line. It has to be normally how much? To an average 87 degrees. And then you are drawing the perpendicular to it. Why? We are drawing the perpendicular to know where are we? 87 degrees, so about to be 90 degrees. This is a normal line for the distal femoral mechanical axis. So we are making a line between where is our angle? Where is our deformity point or deformity angle? Is it articular or in the distal femur? So we have to use another tool to help us to have the site for our angle. How can we do it? We are using now the mechanical axis. Okay, we can use also the anatomical axis. So the mid-diaphyseal point from the lateral to medial cortex and midpoint here, and then mid-diaphyseal point from the lateral to the medial, and we have the midpoint here, and have a line here, what we call the mid-diaphyseal line of the proximal femur, and then another line passes on making an angle on the joint orientation line of the distal femur to have an 81 degrees. As you all know, the anatomical lateral distal femoral angle is about to be 81 degree. So this line will be 81 degree passes like that. Can anyone help us to do it? Dr. Ahmed, Dr. Mosheer. I think we have to do such a training to get accustomed to it. It is a virtual interaction.
Yes, it is very difficult for them. Yes,
yeah,
difficult to be controlled in time because of the technical points. Maybe someone trying to do something but he couldn't because
yes.
of the communication, or his hand is not stable, or didn't
Yes.
oriented, or watching us while we are working, or in his car. This is the virtual problem.
Now Dr. Mosheer is using his laptop. I can see it clearly because he's drawing lines. This is
Yeah.
not on the
Sure,
iPhone. Yes.
Yeah, you may
Yes.
have.
This is a mid-diaphyseal line. You have to correct it a little bit. Dr. Asim, you have to wait, please. Mid-diaphyseal line between these two midpoints, midpoint here and midpoint here, and this we have to do a line. This is a mid-diaphyseal line. Thank you. What about the distal anatomical line? We have to do a joint orientation line to draw it again, and then have an angle line with an angle of 81 degrees, almost to be 81 degrees, to make an angle with this line coming from the upper femur. Thank you. Here is where is our deformity is. Is it simple or difficult? We have to train about it. So in this practical exercise, we used the mechanical axis lines, and we didn't get the deformity point. So the deformity point now is judged by the anatomical axis. You may use both mechanical or the anatomical axis as well. I have to clear all drawings and disable annotation as well. And then to draw, this is my drawing on the presentation. This is joint rotation line proximal femur, joint rotation line of distal femur. This is the line from the center to the center for this femur. And this is mechanical lateral distal femur angle is about 107 degrees. This is the anatomical and the mechanical as well of the tibia. Tibia is not deformed. This is the mid-diaphyseal point of the proximal femur, another mid-diaphyseal point, because we have said that the line is the connection between 2 points. And here is the proximal anatomical line or anatomical axis of proximal femur. And here we have this line is drawn with an 81 degree angle between the red line and the horizontal distal femoral line. This is our point. This is an apex of the deformity, or the center of the deformity, or the core of the deformity. All these expressions are right. This we have an apex of 24 degrees. Thanks to you all that we have seen such a virtual interactive drawing to be done today.
Very nice, thank you. It is difficult for accustoming this technique for many causes I mentioned, but it is a very nice and worth trial for next days. It is a very nice, and we should accustom these virtual tools, inshallah. Thank you. Thank you, Professor.
Thank you. Can we have another last example, or it's enough?
You have just 15 minutes, or we can say that because the praying is nowadays 12, so you can have about 20 or 25 minutes if you have a lecture, if you would like to do a presentation or something. this is a good time to do something before pray. You can lead the next time as you would like.
Okay, let's go to the next presentation.
Stop share and start for your next one. And thank you for this trial for us. And it is an invitation for using virtual tools in our training. Thank you.
You know, my daughter learned me a lot about it.
Yeah, I know. I know.
We have to use our sons and daughters, please.
I know this well. Thank you for her.
I am enjoying to have such a presentation. This
yes,
is,
me too. I would like to listen and watch it many times because it is well designed and more practical than other lectures dealing with this topic. Thank you, Professor Am. Shukran, and you can start.
Yes, thank you. Let's speak about what we call it the temporary hemiphyseal plate. This lecture is done by me and Professor Amr al-Batouti. He's one of our consultants at our National Institute of Neuromotor System. His thesis, an MD thesis, was about the 8 plate, and we have done all cases of the 8 plate in our institute, and he passed his thesis well, and he have got a tremendous very nice results about the correction of such technique. Also, I have no potential conflicts of interest whatsoever to speak about such a deformity we are dealing with the knee deformity, the most common in young children, and an obvious abnormalities that affect the children of the lower extremity, either having a genovarum and genovarum or genovalgum with the most common presentation. This is a very nice table to speak about the causes of genovarum and genovalgum, either to be a congenital cause or dysplastic, or developmental cause or trauma, and also to be a metabolic or osteopenic, and the osteogenesis imperfecta, and also the infection affecting the gross plates whatsoever. But we have here congenital dysplasia developmental. This is the most important cause of the deformity. This is developmental. It's not by the humans. It is no natural growing of the children. So when you see such a patient, is it genovarum? You have to ask about his age to know, is it physiological or not? Is it going to be autonomously or corrected by the growth of these legs? So the legs are most newborn are bowed with 10 to 15 degrees of varus angulation. All of these children, when they were newborn, you may see it as the genovarum. So this concomitant internal tibial torsion might be seen in some cases, exacerbating the deformity. So this is also, don't forget, this is a physiological genovarum. What about genovalgum? This is physiological type of genovalgum, which is a valgus alignment of the lower extremity with a normal child between 2 and 8 years of age. Please remember this age, not to have the decision to do something for him or her. No, please don't do it. Is it seen now? My presentation is on?
Yes, good, good.
Thank you. What about the clinical measurements? We have to measure such an angles, as we have said in the previous example of measuring the angles of the tibiofemoral angle and intercondylar distance of the normal child. Maximum varus happens at the age of 6 to 12 months of age, and neutral alignment will be naturally corrected at the age of 18 to 24 months. What about the maximum genovalgum? It will be at 4 years of age, and the gradual decrease in the genovalgum will be at the age of 8 years. So the child is born by mild genovarum, and then becoming straight at 18th or 24th month, and then mildly genovalgum at the age of 4 years, and it starts correct at the age of 8 years. This is the normal changes happens in these growing children. So what we call it physiological changes in the lower limb. What about the mechanical axis that we have spoken about? This is an obtain a long-standing radiographs, patella facing forward from the highest point of the ilium to the heel, and to be certain the position, the patient positioned in the patella directed anteriorly, and to measure such a deformity. Also, we have another tool that we call it the anatomical axis or the metaphysio-diaphysial axis, as we see here in these angles. These are all the tools to measure such a deformity. What about our hemiepiphysiodesis? Why it is temporary? Why it is hemi? Now we are having the 8 plate with the figure of 8 plate with the 2 holes and these 2 screws inserted inside parallel or just parallel to the physis. This is an extra periosteal tool and extra physial as well, and is flexible as the modulus of elasticity of this plate is judged and allow for growth with an easiness of insertion with a learning curve very limited. When we compare it with the old modality of the staples, its staples are extra physial but not flexible, with not easy removable tool. So what are our mechanics? Here we have the stresses passes from the lower limb proximal to distal, and here we have a stable and the 8 plate. What happens during the 8 plate? This is 8 plate having this load sharing. That means that the stresses from proximal to distal passes in both ways, in the direction of the bone and also passes in the direction of the plate. This is load sharing. What about the problem of the stables? It's a stress shielding. All the stresses coming from the up, represented by the weight of the patient, passes all the stresses here inside this stable. No load sharing whatsoever. It's what we call stress shielding and causing the tremendous affection of these physes, which might not be reversible. But here, due to load sharing mechanics, this when we remove the plate, the cross retain its regularity whatsoever. So the plate here, we can see that the plate and the stable. The stable causes a compression, but the plate, due to swiveling of the screw head inside the plate hole, will allow for divergence of screw from each other, allowing for facilitating the physis to grow, but the degree of growth of these physis or the rate of growth of these physis under the plate is less than the growth the other way on the other side of the plate, or other side of the bone. But here we have the stables causing a compression of the physis that might not let the growth whatsoever happen here under the stable, but the other side is growing. So this is a very nice modality or the biomechanics of growth that we may achieve in this hemiepiphysiodesis. Hemiepiphysiodesis means that screw's length doesn't cross the midline. When it crosses the midline, it will give you a total hemiepiphysiodesis. But here, the growth or the length of the screw will be stopping at the midpoint or the mid-diaphysial line or midline of the bone inserted at. This is an extraphysial fulcrum around facilitation. This is a physial fulcrum inside the physis compressing the physis. This is a very big change. What about this paper? The paper is talking about this principle of facilitating rather than a compression. With the 8 plate, the physis, the correction occurs more rapidly, more than 30%, because the fulcrum is extraphysial. Here we have the fulcrum in physial fulcrum. This is the achieved goals. Very nice. What are the difference now? Here we have the flexible 8 plate and unconstrained, facilitating the physis, load sharing, and it's single. But here we have the stables to compare with. These are the rigid tool, constrained, doesn't allow any divergence or any resilience with the compressing devices rather than facilitating with the stress shielding, and we might use a multiple ones. Here we have this, our virtual learning, to have here some videos to show you this, how can we insert it? How can this plate and screws works? This is a very short video. This is how it works. You insert it at least to be maybe a parallel, just parallel to the devices. It's not needed, but it might be slightly parallel or just divergent. And then while growth or growing of the children, this divergence occurred as you see here in this video. This is the modality of action of such 8 plate. So the application might be applied at any age, at the growing age, at any size. We might use a lot of shapes of these 8 plates. Any accessible physis might be done the temporary epiphysiodesis with growth remaining more than 6 to 12 months. How can we calculate the growth remaining? We have the multiplier application on our mobile phones that we can put inside data about the patient, and we will get the gross remaining tool or the gross remaining measurement. Okay, any diseased physis we might use, and also in the sick physis. Yes, we may use it in the frontal or the sagittal or the oblique planes as well. And a lot of papers are published in the many years before about these modalities of epiphysiodesis. Here the distal tibial epiphysiodesis and plantar flexed ankle. This is a posterior inserted 8 plate in the proximal tibia to correct the recurvatum. This is a genoverum. Don't forget this X-ray. Please, we are going to talk about this in the last slide. This is a patient with genoverum, tibia and femur. After judging the axes, both are 4 plates are inserted. So what are our contraindications for such cases? Closed physis, any closed physis. The diseased physis means that the physis is partially growing. We may use the 8 plate for, but the closed physis is a contraindication for the 8 plate. Physiological deformity, as we have spoken few minutes ago, this is a contraindication because the patient is going to be corrected during his growth. And if the patient is skeletally mature, either male or female, please don't use this modality of correction. What are the types of the screws? Here we have the 4 millimeter cannulated and self-tapping fully threaded screws with the plate sizes might be 12 or 18, and such so many companies having 3 sizes, not 2, and not locking. The screw heads are swiveling in the side, the dish part of the plate hole. This allows for divergence. This is a pre-contoured. This act it's seen like a dome in this plate. It's not a straight plate. It's like a small dome with a low profile, a very thin one. Here are the instruments. Very few, a small set. The 8 plate full set. This is a very easy learning curve to have, but we have to get our tools inside this OR to have the CR, the cannulated drill, and also guide wires to be available with a cannulated screwdriver as well. These are the very important instruments or tools inside our OR. What about the insertion video, or how can we insert it? Let's to start our first video. Here we have a small incision under image, inserting the first wire. First wire will be inside the physis. We had a lot of questions about this wire. This is a very small sharp wire, doesn't affect the physis whatsoever because it is studied well in the literature. It's a mid part of the bone under the image, and has to be inserting the 8 plate on it due to a hole in the middle part of the plate. Here we have a proximal distal hole and proximal hole. we're starting first to drill the epiphyseal hole. Don't forget the epiphyseal hole to be drilled first, then the metaphyseal hole. Bye. How can we drill? You are going to insert a guide wire in each hole, proximal and distal, then to use a cannulated drill. Here we have our cannulated drill, just drilling the lateral or the medial cortical bar, only the cortical part, not drilled all through this shaft of the screw. And self-tapping our screw, this cannulated self-tapping screws, insert the distal first and then the proximal. As you can see here, it's not mandatory to let these screws to be parallel to the faces or parallel to each other. It's not mandatory, it's not the demand. This is our last video to show you how can we insert these screws inside. This is the epiphyseal and this is the metaphyseal screw, allowing for weight bearing for this child immediately after surgery. And we have a very important instructions to the family before the operation. First, we have to encourage the immediate weight bearing of the child post-operatively, and we have to tell the family that the patient's not going to be corrected while he's going out from the OR. He's going to be corrected while he's growing, and we have to follow him up every 3 months. So this follow-up is very important. Follow-up by image, or what we call it, the scanogram, to be repeated every 3 months and to follow the patient with to show or to see the correction of the deformity which happened gradually. And we have to talk to them that we are going to remove these 8 plates immediately after correction of the deformity, and also to speak about it might be repeated. You have to answer these questions. Would it be repeated while the patient is growing? It might be or might not. So here we have the immediate weight bearing routine for this child after the operation. And also we have a small tape while inserting the lateral distal femoral 8 plate. You have to dissect well around the plate, not to entangle the iliotibial band, because when you are entangling the iliotibial band under the plate, you are going to face a limitation of flexion of this patient. So what about the cases? We have a very nice case. This 5 years old boy with the left genovarum, unilateral genovarum, where we can put genovalgum, where we can put this plate. The genovalgum we have to do in an axis planning, and we had our axis planning that the distal femur is the apex of the deformity. So we had to insert our 8 plate here in the medial part or the convex part of the femur. 12 months later, is fully corrected and to be removed. Also, we have a 12 years old boy with growth remaining about 4 years, left genovarum. To insert it in the convex part, and this how it corrected after 16 months with follow-up every 3 months with a scanogram. Let us to finish our talk today about the disasters that may happen due to loss of our patient in the follow-up. Here we have such a patient. He had a bilateral genovalgum. We inserted a femoral and tibial, it was a severe deformity. Can you see now what happened after 1.5 years? We have lost him in the follow-up. It happened like in the plate is bent about to be 90 degrees, and the deformity is reversed from genovalgum to be genovarum. So this is the importance of the follow-up of such a cases. Please have the mobile phone number of each patient family and follow him up. Ask about him if you have lost him during the follow-up period. This is how it's seen. This our young lady having the future of her deformity correction would either to be a physiologic or non-physiologic. And here we have these modalities, other modalities of 8 plates, what we call it a quad plate. This is an 8 plate with 4 holes. It's used for the large weights for our young chaps. And the very recent hinged plate, here we have a hinge in the middle part of the plate and allowing for bending of this plate very easy. And this is used in so many literature. To have our take-home message, please have a proper assessment and planning before your operation. We have the close radiological follow-up, either the pre and post-operative, and also after plate removal. Don't stop following your patient. You have to follow your patient after removal until gross maturation. And lastly, the plate removal timing with new computer application also is indicated on the multiplier application. When you use it properly, you might have the expected date or expected time for plate removal after inserting the proper data of the patient. Lastly, here's my contact. This is my name in the email, Facebook page, and also Pablon Researcher ID. Thank you very much.
Thank you, Professor Amr. As usual, interactive and very nice presentation to clinical tips and tricks. Thank you so much. May I ask a chance for some of our trainee if would like to have the chance to ask Dr. Amr? I think may have a question in the chat. One question, I think. Medial distal femur. I think he was answering about a question you delivered it.
Sorry.
Yes. Thank you, Dr. Mohamed Abdel Alim. He is usually going well in follow-up. Thank you for this pre-praying, very nice, interested lecture. I think you have still 1 or 2 lecture.
Yes,
one?
Yes, I have one more. Yes.
Which is you choose for us? Which one?
Yes, this is a distal femoral osteotomy technique.
So it needs a lot of time. Not enough for this to have this short time. So may I ask our trainee if we have one of our trainee to present one of his lecture? It's okay. Version 11.
Recording in progress.
Lecture. He usually trying to stick to the time, and I find that it is a chance to present one of the active training process and the training program is that few weeks following start we can present a lecture, and if we can't, we can help you to present. If you couldn't, we push you and help you many times to be a good presenter. It is a must for any trainee in the LRS. Thank you, Dr. Mohamed, to be ready at any time as we know you. So it is the time for you. Thank you, Dr. Mohamed, for your presentation. And after that, we will go for pray and return at 1 o'clock at Cairo time. Fadel, Dr. Mohamed.
Thank you, Dr. Fadel, for giving me this chance to be with you. Our topic today is about deformities of metabolic disorders. My name is Mohamed Kamal, orthopedic consultant, LRS 11 trainee, under supervision of Professor Dr. Mohamed Fadel, the program director. What is the metabolic bone disease? It's a fault in the shape, strength, and the structure of bone tissue due to altered bone homeostasis, mineral homeostasis. The three threes. The major factors that affect this homeostasis are the intra and extracellular levels of three ions, calcium, phosphorus, and magnesium. The ion controlled by three hormones, the parathyroid hormone, calcitonin, and the vitamin D. The ions and the hormones act upon three tissues, the bone, kidney, and intestine. The common clinical characteristics of metabolic bone diseases include electrolyte disturbance, fractures, bone deformity, abnormal gait, and short stature. The forms of metabolic bone disease in the children, the most common forms are rickets and renal osteodystrophy, and less common osteoporosis, malabsorption syndrome, inherited diseases like hypophosphatemia and the X-linked hypophosphatemia. Rickets. Although there are multiple types of rickets, the basic pathogenesis is a relative decline in calcium, phosphorus, or both in large enough quantities that interferes with normal mineralization of osteoid matrix in the growing child. Poor calcification occurs at zone of professional calcification, leads to increased physeal width and cortical thinning and bowing. The reduction in the calcium and the phosphorus ion levels may result from insufficient intake of phosphorus or vitamin D, reduced absorption of calcium, phosphorus, or vitamin D, reduced conversion of inactive vitamin D to its active form, or end organ insensitivity. The nutritional rickets, low vitamin D deficient rickets, the cause is vitamin D deficiency in the diet. This leads to failure of calcification of cartilage and osteoid tissues. Thus, radiologically, the physis is wide and hazy in appearance. As we see here, there's cupping and the fraying and widening of the physis. Vitamin D deficiency leads to decreased absorption of calcium and the phosphorus, which leads to hypocalcemia. And the enrolled
Recording in progress.
If the child doesn't respond to oral vitamin D therapy, vitamin D resistant rickets should be suspected. Since residual deformities is very rarely observed after medical treatment, there is no specific orthopedic treatments. Vitamin D resistant rickets, or familial hypophosphatemic rickets. It is the most common form of heritable rickets, usually presented at the age of 1 or 2 years, caused mainly by inability of renal tubules to absorb phosphate, which leads to hypophosphatemia. So, normal dietary intakes of vitamin D is insufficient to complete normal mineralization of bone. The main form is X-linked dominant is the most common type, autosomal dominant, autosomal recessive types, and all these types share in the increased fibroblast growth factor 23. Increase in fibroblast growth factor 23 leads to decrease in renal phosphate absorption and suppression renal 25-hydroxy-1 alpha hydroxylase activity. This leads to hypophosphatemia and rickets. The major complaints are delayed walking and angular deformities of lower extremity. Systemic manifestations are generally deficient. Once affected, genovarum develop when children begin to walk, although genovalgia may occur in these children. Short stature is also a feature of hypophosphatemic rickets. Radiologically, there is widening of the physis and the bowing and the varus malalignment of lower limb. Treatment, medical treatment, the classical treatment consists of oral replacement of phosphorus in large doses and administration of vitamin D. Additionally, treatment by growth hormone administration also increases the height and has positive stimulus on bone density. Recently, analogs of active vitamin D, the active form of vitamin D, calcitrol, have been evidenced to be more effective than the previous vitamin D supplements. Orthopedic treatment. The orthotic management hasn't been effective. Angular deformity should be corrected surgically. The post-operative period should be in close cooperation with the nephrologist and endocrinologist, as calcium levels tend to increase with the post-operative immobilization period. The most common deformity seen in this patient group is a gradual anterolateral bowing of the femur and accompanied by tibia vara. As we see here, anterolateral bowing of the femur. Multi-level osteotomies are usually required. The mechanical axis can be slightly overcorrected. The recommended fixation modalities may be external fixation, internal fixation, or plate fixation. This radiograph shows multi-level osteotomy fixed by external fixator. The renal osteodystrophy. Manifestations of renal osteodystrophy are present in 66 up to 79% of the children with renal failure. Renal osteodystrophy is different from either nutritional or hypophosphatemic rickets. The pathophysiology, failure of damaged kidney to convert vitamin D to its active form, calcitrol, and phosphate retention leads to hyperphosphatemia. Both of them leads to hypocalcemia and secondary hyperparathyroidism. This patient shows the features of both rickets and hyperparathyroidism. Hyperparathyroidism provokes osteoclastic resorption of bone. Serum vitamin D and the calcium levels are low, with increased blood urea, nitrogen, creatinine, and acidosis. Children has a short stature and a fragile bone with fractures. The most common orthopedic pathologies are skeletal deformity, usually genu-valgum, articular enlargement of the long bone, slipped capital femoral epiphysis, and it may lead to muscle weakness and the Trendelenburg gait. Or radiograph, widespread osteopenia with thin cortices due to increased activity of osteoclasts due to hyperparathyroidism. Widespread osteopenia with unclear trabecular exist. The bone has a ground glass appearance. The physes are increased in thickness. In severe and persistent renal failure, aggressive lytic lesions may be present, like brown tumor. The medical treatment usually concentrate in the treatment of the renal diseases. It's a vital importance. Dialysis and transplantation prolongs the survey of this patient group. Medical treatment is started with active form of vitamin D. The use of the active form, calcitrol, decreases serum BTH level and delay the formation of bone change. Treatment of acidosis with sodium bicarb also improves in metabolic bone disease. Recombinant human growth hormone restores these children. However, growth hormone also weakens the physes and stimulates the development of scaphy. Parathyroidectomy may be indicated in refractory cases to treatments. Orthopedic treatment. Patients with renal osteodystrophy usually have three orthopedic pathologies: angular deformity, slipped capital femoral epiphysis, and avascular necrosis. Any surgical intervention in this patient population should be carefully considered, as the perioperative risks are amplified due to anemia, hypertension, bleeding tendency, and electrolyte imbalance. The risk of infection is furthermore increased in patients with a renal transplant who under immunosuppressive therapy. Angular deformities. Angular deformity occurs because of the bone is soft, under-mineralized, and prone to bend with weight bearing. Genu-valgum is the most common deformity, but genu-varum also may be present or wind-swept deformity. The radiograph on the right shows the genu-varum, on the left is genu-valgum, and this is the wind-swept. Some milder deformities will correct with medical treatment of the renal osteodystrophy. Deformities doesn't respond to bracing; it's not effective. If the patient becomes symptomatic and has undergone optimum medical treatment without resolution of the deformity, then corrective osteotomy should be performed. Internal or external fixation can be used. We prefer external fixation because it's a stable construct and we can use hydroxyapatite coated shans pins for good purchase in the bone. But the bone healing may be delayed. Milder deformities may respond to hemiepiphysiodesis. Recurrence is common in patients with continuing metabolic pathology, so medical treatment should be adjusted before and even continued after corrective osteotomy. Elevation of serum alkaline phosphatase concentration above 500 units per liter is a worthy marker of ongoing metabolic bone disease. Elicited capital femoral epiphysis in renal osteodystrophy. The clinical picture differs from the usual SCAFI. The patients are often younger and is not obese, usually bilateral affection. The goal of standard management of SCAFI is to, in cases of renal osteodystrophy, is to end the physeal growth and thus heal the slip. But this may not be an appropriate in young children with renal osteodystrophy. Still, we have more growth. However, physeal healing is compromised due to the metabolic pathological condition. Fortunately, pain and the physeal widening resolves with initiation of appropriate medical treatment. If the slip is displaced or symptoms continue despite medical treatment, fixation with one screw provides stability across the physis without closing it. The hypophosphatasia. Hypophosphatasia is a rare genetic defect of alkaline phosphatase production, which results in pathological mineralization of the bone. There is a wide variations in the severity of the disease, and the prognosis depends on the age of onset, perinatal, infantile, childhood, or even adult. The gene for this disorder is the tissue non-specific alkaline phosphatase gene, and many different mutations have been described. The pathology detected in hypophosphatasia resembles that seen in the patient with rickets. Osteoid production remains undisturbed, but the mineralization can't occur. As a result, the physes are widened and resistance of calcification zone and metaphyseal remnant of cartilage islands. If hypercalcemia is added to the clinical picture, heterotropic ossification foci can be formed. In laboratory tests, alkaline phosphatase levels are decreased in the serum and in the tissue, like kidney and the bone. Serum phosphorus, vitamin D, and the BTH levels may remain within normal. Hypercalcemia in some patients. Characteristically, urine pyrophosphate levels are increased. It's a very characteristic test. Pyrophosphate in urine. Treatment also, there is no conventional medical treatment of hypophosphatasia. Successful marrow cell transplantation will improve the disease in many cases. Fractures and deformities needs orthopedic management. Fracture healing is delayed if deformities exist. Multiple osteotomies with intramedullary fixation are required to correct the bowing and provide structural support to the long bone. This is our references. And thank you. Oh, sorry for long time, exceeding my time. Sorry.
Thank you, Dr. Mohamed, and thank you for all the participants. And may I ask you to have a rest for 1 hour nearly to come here 1 p.m. past 10, and trying to be exactly at 1. We will start, inshallah, time in Cairo, and after that around 2, we will start the Indian ASAMI with Ortho team to share us for this day. Good luck and see you, inshallah, after 1 hour.
Thank you, sir. Thank you, sir.
Thank you, Dr. Mohamed. See you.
فين عمل الحاجة دي؟
لا
كده انت عملت معاه المفروض كده يكون شغال. ايه؟
ده المفتاح من الصوت ده شوف
Recording in progress.
موفقين إن شاء الله يا حبايب بإذن الله يا شباب. We are ready إن شاء الله. بعد الدكتور عمرو إن شاء الله نبدأ محاضرات التريني بتوعنا المميزين ما شاء الله عليكم. ولو حصل أي طوارئ أو زنقنا في الوقت عشان المجموعة بتاعت الأسامي إنديا عندهم they have now in Bangladesh another webinar. They will finish at time and will associate us at 10 exactly. So we would like to finish our program at 2 exactly, inshallah.
السلام عليكم. Unmute yourself, دكتور فاضل, please. السلام عليكم. زي الصح.
الحمد لله على السلامة. شكرا جزيلا.
الله السلام.
Our team جمعا إن شاء الله جميعا وكل سنة طيبين. نكرر لكم التهاني بالأيام المباركة وعيد الأضحى المبارك. والزملاء معظم الأسامي انتر India وأورثو TV are joining now with our friend Dr. Mufakhar Allah Bari in Bangladesh webinar, and they will finish at 2 o'clock to start with us. So we will are enjoying the lecture of Dr. Amr, and then some of our trainee presenting their lectures, inshallah. I think at 1 o'clock we can start exactly because I know some people who are waiting you at time.
Thank you.
For our colleagues, our trainee, if you have time, post the lecture of Dr. Amr. We will go on for our trainee activity. It is extra trainee activity. It is not the assignment only, but they are unique enough to present extra assignment. Thank you for you all, and let us enjoy the lecture of Dr. Amr. And it is a chance to say thanks for also those who are watching us on the stream video on the Facebook and in the link of LRS.PD page and the group, and also in Ortho TV channel. Thank you. تفضل دكتور.
Bismillah ar-Rahman ar-Rahim. Shall we start our last lecture today? Happy to be with you all, and thanks to Professor Muhammad Fadel and his great efforts to accomplish this international meeting. And let's start with the distal femoral results, osteotomy results and complications. My name is Azzam. I'm working in the National Institute of Neuromotor System in Cairo, Egypt. And it's a unique institute concerned with the deformity correction and congenital anomaly, dealing with the congenital anomalies of upper and lower limb surgeries. Also, we are having many departments in our institute regarding the orthopedic department, neurology department, neurosurgery department with a pediatric, and large physiotherapy department, with also a special factory for the compensatory devices and artificial limbs with different walking aids to be manufactured in this unique factory. Let's start with my first slide to talk that I have no potential conflicts of interest whatsoever. To speak about the learning outcomes from this lecture, we are speaking about, does it the virus opening wedge osteotomy has the privilege on the virus closing wedge? To enlighten us about what pain and function levels do the patient experience after wedge osteotomy, and also what are the complications and the reporting the operations after the wedge osteotomy as well. As we all know that we have spoken about these two axes in the lower limb, the mechanical axis from the center of the hip to the center of the ankle, passing through the center of the knee, and the anatomical axis, the mid-diaphyseal point of the femur and tibia, having a special angles with each joint orientation line regarding the orientation line of the hip, lower femur, upper tibia, and distal tibia. This is a modified standard measurement with the sagittal plan as well, from the center of the head of the femur to the center of the ankle. We are repeating ourselves so many times because it's very important to do for each patient with the distal femoral osteotomy to do a pre-operative planning. Plan to fail is a failure to plan is a plan to fail. So what's our planning? We are concerned about standard X-rays, AP and lateral and skyline views of the knee, patellofemoral articulation as well to be seen. Standing scanograms with a special consideration to the patella facing forward, the patient standing with no flexion deformity whatsoever, and from the ilium to the foot. Also, we may have an MRI to judge or to have an idea about the ligamentous integrity of such a patient, because whenever you are going to have any laxity, your decision might be changed. And also to judge the articular cartilage in the opposite compartment. Whenever we are going to do an osteotomy, we are redistributing the forces from the lateral to the medial compartment in case of valgum. So we have to know the condition of the articular surface of the medial part of the knee. Also, arthroscopy might be a good tool for the intraoperative judgment and tool for help of the correction of the inclination in the lateral view and AP. And also to judge the articular surface and to do whatever it takes to improve the articular surface. So this is the MRI for one of our patients having the subchondral edema in the lateral compartment with a genovalgum with a synovial effusion, but the medial compartment is intact and healthy, and this is a good tool for judgment of our medial compartment condition regarding the cartilage and articular surface. Also, we have the plan for the preoperative plan. We have here the apex of the deformity in such a patient with a standing scanogram with a 23 degrees. And he have done the operation with a post-operatively corrected by angled plate with not a recent modality for correction, but one of the tools to correct such a deformity. Also, we may have the recent varus open wedge plate with a modality of the census modality, and other companies have the copy from it. And this is with a special wedge here to maintain the open lateral wedge osteotomy for this correction. And this wedge is having different sizes. But the stability of such a construct is questionable. What about the next one? This is the angled plate. Angled plate was we call angular stable. This angular stable LCP, locking compression plate. This is a plate with a unique internal fixator design. It acts as an internal fixator. It's not to be fixed, just compressed to the surface of the bone. And the screws are inserted with a 3-point of contact. First, the point of contact with the lateral with the plate, and then the point of contact with the near cortex, and the third one with the far cortex. So each screw having the 3 point of contact with a great deal of stability for such a construct. This is a post-operative radiograph showing the varus open wedge using such a plate with lateral translation if needed to minimize the wedge to be opened. As you all know, whenever the osteotomy is not at the level of the apex of the deformity, a translation might happen, and the plate is translated laterally away from the bone, denoting this is a segment of the distal femur lateral to the proximal segment. This is another modality of the varus closing wedge of the plate inserted medially and removing a bone stock from here, from the distal femoral bone stock just above the condyle. Regarding this video, to show us how it goes with such an osteotomy, and first do a planning. This is a planning with the English style, doing the plan with the line from the tibial axis. This is maybe anatomical and at the same time the mechanical, and to extend it proximally. This is a proposed mechanical axis of the lower limb, and here we have to let the head femur to pass in this line. So we subtract from this angle, from the mid-diaphyseal line of the femur, this making a large angle. We have to subtract 7 degrees, which is called the angle between the mechanical and the anatomical axis, and then to measure the angle between this line and that line, which is called the deformity axis. It's 12 degrees. About this one, we are having the video showing the lateral incision, just direct lateral incision on the distal femur. You know, this limited, what we call it, a minimal incision regarding the length of this plate, showing the distal femur between the vastus lateralis and iliotibial band. And here we can insert the plate, inserting the plate extra-periosteal. As you all know, this plate is not for stripping of the periosteum, maintaining the blood supply of the underlying bone. Extra-periosteal submuscular, and then judging the level of the osteotomy under image intensifier in the OR by K-wire, removing the plate and electric saw, keep maintaining the medial part of the osteotomy intact, incomplete osteotomy, depending on the osteoclasis that will happen on the medial cortex. Why is that this osteotomy is oblique from superior lateral to inframedial? This because literature reviews and studies judged that the distal femoral, this side of distal femur, is a resilient part with the metaphyseal barrel shape and allows for more osteoclasis at this side, maintaining the contact of the cortex or intactness of the cortex of the medial aspect of the femur, if needed. Then, after that, we are going to open the osteotomy site by distractors, very, very cautiously, gradually maintaining the intactness of the medial cortex. Here we have the correction. How can we judge this correction that happened? By the cord method. This is the wire for the diathermy in the OR to be stretched from the head of the femur, center of the head of the femur to the center of the ankle under image intensifier, and it has to pass here in the center of the knee, denoting the full correction of such osteotomy. After this distraction to be maintained, the plate is inserted with a special sleeves. This is a LCP, locking compression plate, and this is the sleeves to hold the plate and to insert a guide of K-wires to temporary stability of this plate, and then to start to drill for the screws. This is a locking head screws, proximal and distal to this osteotomy to fix the corrected osteotomy angle. After finishing fixation with the screws, we may close the wound properly, and a very easy one to close it. Sorry, I have to show you this video. So it's not working, sorry. This is a closure. This is a minimal for minimal incision, and there's also a limited incision with a minimal sutures. So, based on these studies, a wide variation exists in the amount of correction as well as the final alignment correction to be achieved. For this entity, we have to remember that this acute correction of the valgus deformity with this modality of treatment, it's not more than 16 to 18 degrees. More than that, you have to do this, what we call it, complete osteotomy with a translation, or to be replaced by any other modalities like an external fixator with gradual correction. So what are the advantages of this technique? We are having here the advantages of the varus open wedge technique over the varus closing wedge. First, it's a single bone cut away from the important structures like the vascular structures, and better control of the amount of correction is done by the cord method and distractors. More anatomical correction of the typical pathoanatomy to excessive distal femoral valgus to be achieved, and also the lateral translation of distal femur allowed by this modality of fixation by LCP as an internal fixator can be done. Also, the advantages of open wedge osteotomy was associated with the improved pain and function with the 5 years survivalship for 74% and 92% in the arthritis and joint preservation, respectively. This was published a few years ago. So our studies on the varus closing wedge technique report mean improvement with the deformity angle between the range of 11 to 16 degrees. Also, this correction, the studies on alignment correction are needed for a clinician too. Further studies are very important to determine the optimum position of the mechanical axis and to decide where the opening wedge or closing wedge osteotomy is better, and to provide the optimum improvement and alignment for our patients. This is an important tool but be used in some modern hospitals. This is an image-free navigation. This is a navigation system, especially to monitor the lower limb alignment and the correction in the coronal, as well as in the sagittal view or sagittal axis in the same time, which is a very important tool to be used. What about our complications? We all know everything have its complications. So The wedge osteotomy having the over or under correction might happen. Patellar instability with lateral subluxation. As you all know, in genovalgum, there is a patellar maltracking in the lateral patellar articular surface. There is infection and might be a lateral pain. Injury to the femoral artery and vein might happen due to insertion of the sharp tools from lateral to the medial direction. Nerve injury might happen in some cases, but proper application of the levators and something like that prevents such a complication. Compartment syndrome due to ooze around the wound, inside the wound, and infection might happen. This delayed union or non-union. The last 4 complications are very minimal in such a technique. Regarding the complication, the most common complication that you may be concerned about is the varus open wedge osteotomy with a lateral plate, was which the removal of the hardware. The plate is having the friction with the iliotibial band. Due to that, this might be the cause of removal with another operation. So you have to speak about this complication very well about it with your patients. Regarding the disadvantages, which is the frequency of hardware removal, the varus open wedge osteotomy was higher than the expected, and that should be discussed with our patients. With the 20% of our patients who had a varus open wedge osteotomy underwent hardware removal. This was published in 2014 in the Clinical Orthopedics Related Research Journal. In Sentina et al. 2014, having the great results with the reports of the 31 knees underwent varus open wedge distal femoral osteotomy. The follow-up from 1.6 to 9.2 years follow-up. This is a large period of follow-up. According to the IGDS score, this is the International Knee Documentation Committee, the score of the knee improved from 36 to 53. The great improvement of this score means the success of such a technique. What about our take-home message? The further studies should focus on improving the accuracy of limb alignment regarding our tools for fixation, tools for judgment intraoperatively and preoperatively, and including the largest studies comparing varus open wedge versus closing wedge osteotomy, femoral osteotomy. And the correction is the best to be applied at the apex of the deformity. This is one of our mandating rules. And correction at another point might lead joint knee obliquity or joint line obliquity. Otherwise, you may do a translation. And alignment is a primary importance. Nothing we do succeeds without it. This is an importance of our take-home message. These are my references for this presentation. I was happy to be with you all. This is my contact. You may have it anytime to contact with me and having your feedback and your questions if I am not allowed to do it so in the short period of time. Thank you to you all.
Thank you, Professor Amr. As usual, interested lectures. I enjoyed it so much. And now we may ask the audience and participant if you have some question for Dr. Amr.
It's Dr. Mosheer Ziadi with you.
And Dr. Mosheer, تفضل.
Thank you, Dr. Amr, for the lecture. My question, what is the maximum degree of deformity for internal fixation?
It's a wide range answer. I am not going to answer it well because we have in internal fixation, we have to do a proper studies before answering such a question. Regarding the distal femur for the internal fixation with acute correction, it is the multicentric study that had been published 3 years ago, I think, or 4. The maximum was 20 degrees. But in the centers that had used such a technique for acute correction with internal fixation, they had a major or large problems in their cases. So it is stated that 16 degrees or 16 to 18 degrees is the maximum allowed correction angle for such a technique.
Okay, thank you. One more question, please. What's your opinion about using bone graft in open wedge osteotomy? Is it necessary or?
Yes, thank you very much. This is a great question. You know, as the tomo effects of the proximal tibia, as well as this technique in the distal femur, which is called also now the tomo effects of distal femur, there's a great debate about this usage of the bone grafts. For our special experience and from the literature as well, there is no difference between using a graft or non-using the graft whatsoever in your such a correction because of the wide surface area of this lower femur and this great callus to be happening with the stability allowed by the implant, which allows for what we call the relative stability, allowing for callus formation very soon, within 6 to 8 weeks. But with my humble experience, please don't do a graft. Don't put a graft, whatever the graft is, allograft or a synthetic graft, because you are going to have a great healing within a very short time.
Thank you, Dr. Amr. Thank you very much.
You know, may I complete that there is a great importance of this technique to have an immediate range of motion after the operation, I think within one or less than 1 week, to allow the patient with having a painless range of motion, which is a great achievement in such a correction. As you all know, as early as possible, that we allow the patient for the range of motion to prevent the complications that might happen in the knee.
Thank you, Dr. Amr. Any question, dear colleagues? Any something, some notes in the chat? I think no.
No.
Okay, thank you, Dr. Amr, again. And now we have again our friends from ASAMI India and also TV. They are joining us now. And it is a chance for us all to watch some of our activities the trainee will present them. Who are ready from you, dear colleagues?
نعم, I will present.
Excellent, excellent, Dr. Sabah. I have the honor to present one of our colleagues. Actually, I am honored to present a very good group in the LRS this year. Dr. Sabah from Iraq will present for us his talk as an extra assignment. It is more than needed from him, but he usually from every now and then, he and some of our trainee present some unique lectures such as this one he will present it for us.
Clear?
But yes, it's okay now.
Is it okay?
Yes, okay now.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. My topic is external fixation for upper extremity trauma. I am LRS trainee, Dr. Sabah Yahya, under supervision of Professor Dr. Mohamed Fadel. External fixator used in distal radius fractures. The distal radius fractures are the most common fractures, accounting for 17% of fractures in the elderly populations. And its treatment is challenging because of accompanying osteoporosis in this population. The advantages of locking plates in osteoporotic bone stabilization were recognized. They became widely used as the treatment of choice in distal fractures of radius. Low energy fractures with no comminution. Volar locking plate is the current gold standard because it enables stable osteosynthesis and early joint mobilization. However, in high energy fractures with many fragments, it is almost impossible to provide anatomic repositioning using open approaches. In such cases, fixation without opening the fracture and repositioning of fracture fragments by ligament or axis make the external fixator a feasible option. Distal radius functional anatomy, the wrist joint has the capacity of 90 degree of flexion, 80 degree of extension, 20 degree radial deviation, and 30 degree of ulnar deviation. Also has the volar tilt of 11 degree with 22 degree of radial inclination. The normal X-ray parameters for the distal radius are as follows. The radial length is about 11 millimeter. The palmar tilt is 11 degree, and the radial inclination is 23 degree. These angles should be maintained close to anatomic values during treatment in order to achieve optimal functional outcomes. Protection of the radial length is important to prevent possible arthrosis of radiocarpal and radioulnar joints. The volar tilt was the most effective radiological parameter on functional outcomes. Classification of distal radius, there are many classifications like Brickman, Fernandez, and AO classifications. The basic factor that determines treatment is involvement of the articular surface. The main goal of a treatment is to protect anatomic features and to keep the joint surface compliant. The Frickman classifications based on involvement of radiocarpal joint or radioulnar joint or both joint plus minus involvement of a fracture of ulnar styloid process. That's the classification to 8 types. Also, there is AO classification for distal radius, either extra-articular, which is type A, or partially articular, type B, or completely articular, type C. The treatment options for distal radius fracture are either closed reduction and cast, or closed reduction and percutaneous spinning, or open reduction and plate with a screw fixation volar or dorsal plate, or by non-bridging external fixator, or bridging external fixator, or by locking plate. The studies comparing internal and external fixation, it was shown that anatomy could be better restored with internal fixation. However, some other studies reported no difference between the treatment methods. And other studies found no functional difference between external and internal fixations. They compared also the bridging versus non-bridging with external fixators and found that both radiologic and functional outcomes were in favor of non-bridging external fixators. They also suggested that non-bridging external fixation was the treatment of choice for unstable fractures of distal radius that have sufficient space for the placement of pins in the distal fragment. The external fixation distal radius by using wrist bridging fixators is used in unstable distal radius fracture. It provides reduction of fracture fragments by ligament or axis by stretching of radioscapholunate and radioleunate ligament. The excess or long-term stretching more than 3 weeks may lead to joint stiffness and reflex sympathetic dystrophy. The medial die punch fragment cannot be reduced by ligament or axis. In this picture, we are showing the die punch fragment, which is the volar leunate facet. The wrist bridging external fixator application technique using 4 Chance screws are inserted, 2 in the second metacarpal bone and 2 in the radius proximal diaphysis. The Chance screw in the second metacarpal should be parallel to each other at an angle of 45 degrees to the horizontal plane, and in the shaft of the radius should be between the brachioradialis and the extensor cardioradialis longus muscle. After reduction, the joint part is tightened and multiple K wires may be delivered percutaneously to increase the stability of fixation. That picture is showing the type of fixation of distal radius with multiple K wires. This is a bridging type of fixation, and this picture of a clinical case with distal radius fixation with external fixator. Non-bridging fixator were reported to achieve better functional outcomes, but indications are limited when compared with bridging fixators. It's used in non-bridging fixator in fractures when there is sufficient space for placement of pins in distal fragment, like in Colles fracture. The external fixator also used in elbow fracture dislocation. The elbow joint is the second most common site for dislocation following the shoulder joint. The dislocation either simple or complex when there's associated with the fracture, like the radial head fracture or coronoid capitellum or trochlea or olecranon fractures. The most common of such complex condition is called the triple triad, which consists of elbow dislocation with radial head fracture and coronoid process fracture. The treatment aims at providing a stable and functional elbow. The surgery is required for stability in such injuries, complicated injuries. Structures that need repair or fixation may be determined based on stability at the operation. From lateral structures, the lateral column stabilization is obtained through osteocentesis or radial head prosthesis together with lateral collateral ligament repair. In coronoid process fracture is fixed either by suture, screw, or anatomic plate. Medial collateral ligament repair is performed if necessary, and external fixator may be applied in the presence of instability or to maintain the achieved stability and to support early joint movement. The hinge external fixator application technique in the elbow joint if stability is not achieved with open reduction and internal fixation in complex elbow dislocation, the joint should be stabilized using one type like a Mayo type hinge unilateral external fixator. The biggest advantage of external fixator is to support early joint mobility while protecting the stability. Thus, that will prevent the stiffness. To place the fixator properly in the elbow, the joint rotation axis should be defined. To do this, the trochlea and capitellum should be superposed, and a perfect circle should be obtained on lateral image when the elbow is at 90 degrees of flexion. The rotation centers of the joints and fixator should be superposed by delivering a K-wire through the midpoint of this circle and should be parallel to the joint. The central hole of the fixator is delivered through the K-wire from the lateral side with two shunt screws fixed to the ulna and other two screws are inserted to the distal humerus. 4 or 5 centimeter incision also should be made in the distal humerus for shunt screw, and the radial nerve should be explored and found and screws fixed. After fixation, the joint movement should be controlled and K-wire should be removed. This picture is showing the hinge fixator for the elbow. The complications of elbow fixator are not low. Redo surgery may be necessary if the rotation centers are not correct. Also may have radial ulnar nerve damage or pin site infection. External fixator in the upper limb can use also for salvage procedures like in destruction interposition arthroplasty. When elbow prosthesis is not preferred in a young active patients with the potential use of the elbow in heavy activities, in such cases, destruction interposition arthroplasty is one of salvage method that can be preferred. In this method, we use Achilles tendon allograft is preferred for interposition. And following interposition, a hinge elbow fixator is used for destruction to protect the interposition during healing for 6 weeks. This picture showing the interposition arthroplasty with Achilles tendon allograft with the hinge fixator destruction. Also, fixator can be used in diaphyseal, humeral, non-union. Non-union rate varies between 2 to 30% following conservative treatment, while it is between 2.5 to 13% following surgery. There are various alternatives for treatment of non-union of the humerus, like dead screw fixation, which is a proven treatment method for non-unions, but it is not a choice with infection or bone defects after surgical treatment. In this case, thus external fixation comes in such cases. The circular external fixations seems to be the successful treatment in diaphyseal humeral non-unions because it corrects the surgical deformities and it enables the bone transport after segment resection in infected patients. However, circular fixation of a humerus is not easy for application and patient comfort is low. Thus, it is preferred in patients who have undergone many operations and in case of infection. This X-ray showing implant failure and non-union of distal humerus and then change to circular frame fixation. Unilateral external fixator application can be preferred as it is easier to apply than circular fixation with a higher patient comfort. And also it provides sufficient stabilization and enables compression destruction. The humeral external fixator application technique self-appearance, which is important to be known, and to protect neurovascular structures, and shunt screw is preferred rather than K wires. In general, the binning of the proximal humerus is accepted as safe. The bin can be delivered from anterior lateral to posterior medial by staying lateral to bicipital groove in 5 centimeter area from the acromial lateral limb, which is safe for the axillary nerve. In distal humerus, the anterior lateral region is accepted for pinning. In mid-diaphyseal region, the radial nerve is crossing posteriorly, therefore lateral and anterior lateral application is safe and accepted for insertion. In distal diaphyseal and metaphyseal region, because of radial nerve is crossing from posterior to anterior, therefore a small incision should be made. In distal supracondylar region, a shunt screw should be delivered from lateral to medial, whereas a KYR should be delivered from medial to lateral to protect the ulnar nerve. This is the same patient with implant failure after dissection and exploration of radial nerve, then application of a circular frame. The X-ray after 2 months will show healing of the fracture. And that's the reference, and thank you for all.
Thank you so much, Dr. Sabah. Thanks so much for your comprehensive lecture. I was afraid that you can collect all this complex lecture in this tight time, but you are fully detailed in a reasonable time. Thank you, Dr. Sabah.
Shukran jazeelan.
Do we have a colleague?
I can present Professor Fadel if you don't mind.
Welcome, Dr. Heshmat. We have just in time now. Dr. Heshmat, please also stick to the time. You can present and share your screen.
Okay, everybody can see my screen now?
Yes, okay.
Initially, I want to say thank you so much for giving me this chance to give a short presentation. My name is Mohamed. I'm a trauma and orthopedic registrar, and I will give a short presentation on the management of bone defect using the induced membrane technique under supervision of Professor Mohamed Fadel. My objectives from this presentation will be a brief introduction about the bone defect, then the definition of this technique and what are the indications, and then briefly I will go through some basic principle science and surgical principles as well. And finally, I will go through the outcomes and the complications. there are many causes for the bone defect. It could be post-traumatic or post-bimental, for whatever, for septic or non-septic causes, or even after the tumor removal. And the options for bone reconstruction could be using the intercalary bone transport with destructive osteogenesis, or using the vascularized bone graft, cancellous autograft transfer, or synthetic calcium-based filler. And these options may be supplemented with the addition of demineralized bone matters or allograft or bone morphogenetic protein. And we have the induced membrane technique or musculate technique. So, musculate technique is a technique for management of bone defect by inducing a membrane formation and then adding a bone graft at a second stage. And this membrane has specific characters which stimulate the bone healing. We can use this technique in management of bone defect, whatever the cause of the bone defect, traumatic infection or non-infection, non-union joint fusion, or even in cases of the congenital pseudoarthrosis. In this technique, a cement spacer is used to stimulate a foreign body inflammatory reaction and ends by formation of an organized pseudosynovial membrane, which is very rich in the inductive molecules. And almost at 6 weeks, we will find 1 to 2 millimeter of non-adherent thick membrane is formed and characterized by high vascularity with osteoinductive and osteogenic properties. And it contains a lot of growth factors which stimulate the bone healing process. The phenotype of cells of this membrane are quite similar to the mesenchymal cells, and it has a similar morphology to the periosteum. For the surgical technique, there are 2 stages with 4 to 8 weeks interval between the 2 stages, starting by the first stage. The first and one of the most important steps is the debridement, and it should be radical debridement and eradication of all infected or devitalized bone or soft tissue. And it is highly recommended to send some deep tissue samples for microbiology analysis. Then after that, we have to stabilize the bone. Whatever we can use the external fixation or internal fixation, IM nail or plating. And then the next step will be application of the spacer. And using the polymethyl methacrylate cement as a spacer, and there are few recommendations or considerations that we have to be aware about it during this step. First, during the placement of the cement, it should be at the late stage of the polymerization to limit the interdigitation between the cement and the cancellous bone. And we need to invaginate the cement in the medullary canal, or we can use K-wire just to avoid the migration of the cement. Second, the cement spacer should overlie the normal periosteum at both ends of the defect for at least 1 centimeter, and this to facilitate the induction of the membrane away from the defect area. We can use the antibiotic, but we have to be aware about musculate himself. He didn't use antibiotic, and he doesn't recommend to use antibiotic with the semen. Of course, the keeping good soft tissue envelope or containment is a mandatory during this process. Otherwise, we will not be able to do good debridement and to keep the spacer. After 4 to 8 weeks, we can start the second stage by carefully and very gentle handling the induced membrane to maintain its integrity and vascularity. And then removal of the spacer, and then the bone graft. And for the bone graft, we can use either the cancellous autograft, for example, from iliacus, or even we can use the RIA, which is Rima Regato Aspirator from femoral shaft, for example. And the RIA technique showed almost equivalent or even superior results in comparison with the iliac crest bone grafting. Lastly, we have to very nicely suture the membrane without any tension over the grafts. For the outcomes, there are many studies showed different outcomes from using this technique. This is the first paper published by Mosheer himself in 2000, and he presented about 35 cases of segmental bone defect in the upper and lower extremities, and the defect sizes were from 4 to 25 centimeter. And again, he didn't use antibiotic. The overall healing rate was 100% from this study. In 2009, he published another paper and showed, and it was a prospective analysis of 11 patients treated with the same technique, plus using the bone morphogenetic protein. In this case, the bone defects were from 5 to 18 centimeter, and the overall bone healing was 91%. And he noticed some local partial resorption of the grafts in all cases. Another study published by Paul Stafford in 2010, he used the RIA technique as a bone graft, and he presented 25 patients with 27 segmental bone loss of the lower extremity. The defect size ranged from 1 to 25 centimeter, and the overall healing rate was 90% at 1 year follow-up. This one of the most recent studies published in muscular technique in 2019, and they reviewed 11 studies and case reports from 2000 to 2018 with more than 500 defects. Most of them were in the tibia, and defect size ranged from 1 to 25 centimeters. The overall success rate was 86%. So here are some complications about it in the literature from this technique. This paper published last year and reviewed about 41 studies with more than 600 patients. And the most common complication was the non-union in about 8.9%. The main reason for the non-union was insufficient bone graft or improper handling of the induced membrane, especially in managing the large defects. The second most common complication was the deep infection, which was about 8% of the cases. And the main reason was in suboptimal surgical deployment during the first stage. In about 3% of the cases, there was malunion, and in another 3% had amputation as a result of uncontrolled deep infection. Some other complications, less than 1%, like the refracture, implant failure, or flap failure, or leg length discrepancy. So the take-home messages from this short presentation. The induced membrane technique has very good and effective outcomes, and the pre-operative planning and proper surgical techniques, especially the deployment in the first stage and the bone grafting in the second stage are essentials for better outcomes and less complications. And these are my references. And thank you.
Thank you so much, Dr. Mohamed. Very good to succeed to give us a good idea about vascular technique in this short time. And it is a chance to ask about hello, I found that we have some colleagues from the States. Lewis, Dr. Lewis, welcome. How are you? It is a pleasure to share us.
Yeah.
Welcome. Dr. Shamsul Hoda with us and your team? That's okay. So we still have a few minutes for Dr. Azzam Al-Taib. Are you ready to present your presentation?
Assalamu alaikum.
Alaikum salam.
Bro Mohamed. Yes, I'm ready.
Okay, try to be in time, please. You saw that we are going well in the program, alhamdulillah. So share your screen and start. We would like to be ready at 2 o'clock exactly for ASAMI, India, and also TV team. تفضل دكتور عاصم.
شكرا.
Welcome, Dr. Azzam. Dr. Azzam was one of our trainees from Sudan. He presented a very nice presentation and extra assignment usually, and this is one of his extra presentation in the training program. Fadel, Dr. Azzam.
Assalamu alaikum. I'm Dr. Azzam Al-Taib, LRS trainee. I'm going to present a case, chronic osteomyelitis and bone defect, supervised by Professor Mohamed Fadel. This is a case of chronic osteomyelitis with a 5 centimeter bone defect. It was treated with muscular technique followed by Elizarov. It's from limb lengthening and reconstruction surgery case atlas. So it's this is an example of an acute heterogeneous osteomyelitis that progressed to chronic osteomyelitis due to a significant necrotic bone segment, secondary to a subperiosteal collection of pus. The patient was treated with multiple episodes of irrigation and debridement, as well as a local control via antibiotic cement beads. The muscular technique was then used to address the segmental bone loss. This was subsequently complicated by a pathological stress fracture through the healed graft, leading to a hypertrophic non-union. The hypertrophic non-union and deformity were treated with a distraction with an external fixator. This is a case of 11-year-old girl who presented with a 2-day history of progressive left ankle pain, fever, nausea, and vomiting. She was seen in the local emergency department and had radiographs to the ankle, which were read as normal, and was sent home with a diagnosis of stomach flu. She presented 3 days later with persistent fever and inability to bear weight on the left leg. At that time, she underwent a bone scan, which demonstrated osteomyelitis, and was admitted to the medical ward for IV antibiotic treatment. She did not show signs of improving after 6 days of IV antibiotics and underwent an MRI, which showed a subperiosteal abscess around the distal tibia, and the orthopedic department was consulted. Patient was taken to the operating room several times for irrigation and debridement, but the pus continued to recur. Due to the worsening condition of the patient and the unsuccessful debridements, a second MRI was performed and demonstrated a necrotic bone segment of 5.5 centimeter. The patient was treated with a local antibiotic beads, which was exchanged twice at 2-week intervals, and aggressive debridement of all necrotic tissues. The family was given the choice between a musculae and or a bone transport to treat the segmental bone defect. The musculae technique was chosen and healed, but was complicated by a stress fracture through the graft site that developed into hypertrophic non-union. The hypertrophic non-union was treated by destruction of the non-union. The X-ray on the left shows a normal radiograph, AP lateral, no abnormalities, and on the right it shows subperiosteal pus collection in the distal tibia. The radiograph shows on the left necrotic bone segment, and the MRI on the right shows a necrotic bone segment of 5 centimeter in the distal third tibia. So preoperative problem list. First, acute hematogenous osteomyelitis with subperiosteal abscess. Second, chronic osteomyelitis with a 5.5 necrotic bone segment in the distal third of the tibia, and local soft tissue concerns for wound closure. Third, complication of the musculae by a stress fracture through the healed bone graft and subsequent hypertrophic non-union. The musculae technique, just a quick words, it's a technique used to treat segmental bone defects. The initial bone defect is filled with a block of cement with or without antibiotics for 6 weeks. During this 6-week period, a vascular membrane forms around the block of cement. The surgeon then carefully opens this membrane and replaces cement with cancellous bone graft. In this case, the fibula was intact and the block of provided enough stability to immobilize the patient in a cast. However, an anteromedial skin closure was an issue, and the VAC closure was applied over the musculae site until skin closure was achieved. 6 weeks later, the bone grafting procedure was undertaken and the circular X-fix was applied to stabilize the leg. Primary skin closure was possible at that time, but an incisional VAC was applied as a safety precaution. The bone graft healed after 8 weeks and the patient was permitted to weight bear with the external fixator. The external fixator was removed and the patient was placed in a patellar bearing Sarmiento type cast for 4 weeks. The patient was then allowed to weight bear as tolerated and began physiotherapy. 6 weeks after her cast removal, she had a stress fracture through her bone graft, which was treated with reapplication of a below knee cast. Unfortunately, the stress fracture went to hypertrophic non-union and a recomberatum deformity of the distal tibia, which did not heal despite use of conservative measures, such as a bone stimulator. A circular external fixator was applied and destruction of the non-union was performed at 0.5 millimeter per day, along with correction of the recomberatum deformity. After 20 days of destruction, compression was applied for 10 days. The patient was encouraged to wear bait as tolerated and X-fix was removed 2 months later. The patient was placed in a patellar bearing Sarmiento type cast for 4 weeks and then switched to a clamshell ankle foot orthosis. So the basic principles in acute hematogenous osteomyelitis in children can often be successfully treated with IV antibiotics. However, when the clinical condition of the patient does not improve quickly after IV antibiotic treatment, the physician needs to investigate for subperiosteal abscess or other potential causes for the delay in response. In this case, the subperiosteal pus persisted for several days and effectively created a compartment syndrome which led to bone necrosis. Once the presence of necrotic tissue is established, IV antibiotics are no longer an effective treatment. So aggressive local control by debridement of all necrotic bone and soft tissue and placement of cement, antibiotic cement beads is necessary to eradicate the infection. The peak elution of antibiotic beads occurs around 5 to 7 days after placement and drops very low to very low levels after 14 days. Therefore, exchanging the beads after 2 to 3 weeks in cases of severe infection is recommended. Furthermore, reassessing the local tissues for necrosis and debriding back to bleeding tissues need to be done during each return visit to the OR. Once local control is achieved, then the segmental bone defect can be treated either by bone transport or muscular technique. Antibiotic beads have an elution time for 5 to 7 days. Once elution ends, they become a foreign body. Therefore, exchanging the beads at an interval of 2 weeks is recommended. If a medullary infection is suspected, insertion of the beads can be performed through a proximal lateral entry, just distal to the growth plate, and flexible reamers can be used over a ball tip guide wire to help prepare the canal for the beads. Special attention to the soft tissue envelope is critical after multiple return visits to the OR using the same incision. An incisional vac dressing can help prevent wound adhesions, or a vac may be required if primary closure is not possible. The radiograph, the X-ray, or the picture on the right is an intra-op photograph, and it shows the trough created for debridement and passing of the antibiotic beads, as well as the necrotic bone segment after debridement. On the right, we can see a CT and shows the placement of intramedullary beads. The musculae block of cement can be seen. Figure A is an intra-op photo of induced membrane surrounding the cement block. At the time of cement removal and subsequent iliac crest bone grafting of the defect and closure of the membrane. This figure shows the AP radiograph of the TB after X-fix application and bone grafting and of the bone defect following membrane induction with the muscular technique. AP and lateral X-rays of the left tibia 6 weeks after frame removal. They show healing of the bone defect. These X-rays they demonstrate a stress fracture through the healed bone graft 3 months post-frame removal with development of hypertrophic non-union with recumbratum deformity of the tibia. The lateral X-ray of the left tibia after distraction and deformity correction of the non-union using an external fixator. Lateral and entire length X-rays, they demonstrate.
I think you should be in a hurry for your time, please. Yes, excellent, good.
Take-home messages. Accurate diagnosis of acute osteomyelitis in children is critical to initiate treatment. When a child presents with inability to bear weight, further imaging should be requested to rule out septic arthritis or subperiosteal abscess. If the clinical condition of the child does not improve in 24 to 48 hours of IV treatment, advanced imaging is requested. In chronic osteomyelitis, aggressive debridement of necrotic tissues and bone is vital to successful eradication of the infection and can require multiple returns to the OR. In persistent cases, local control via antibiotic IV cement beads can be very helpful. These are my references. Thank you.
Thank you, Dr. Azzam. I am so pleased that you, as one of the trainee of generation LRS 11, presented this nice presentation about this case. It is a very nice and in a reasonable time. And now it's time. Thank you, Dr. Azzam. and you are a moderator. I hope that you continue with us. And may I have the chance to talk? I found that now our friends and team from ASAMI India and Ortho panelists, we are now with us. You can unmute and uncover your video, I think, by yourself.
Sir,
Yes.
I'm not. My video is stopped, sir. Please allow, sir. I cannot do.
I think I
Need
will
to
check.
request to IT, sir.
I will check. Abdurrahman, please, Mr. Abdurrahman. Dr. Shamsul Hoda asking that he couldn't uncover his video. But I think I have now Dr. Rajat uncovered his video. He now is in front of me, and Dr. Jeetendra also. He, Mr. Abdurrahman, Dr. Shamsul Hoda, you couldn't share your screen?
No, sir, I cannot start my video. I'm not allowed.
I cannot also start my video. Somebody is blocking it.
You can't share. You may be from the other link, not from the link that we send it
From
to
the
you.
same link, sir. It was,
no, you can do it.
Because the host has stopped it. It's saying the host has stopped it.
No.
The host need to allow me. Kindly allow me, sir.
Am I visible?
Yeah,
yes,
ma'am.
Yes, you are visible. Yes.
Okay,
good.
thank you.
Dr. Rajat and Mini. So, Abdurrahman. Mr. Abdurrahman. Dr. Shamsul Hoda asking us to unmute him and to open the video for him. He couldn't do it. Is it possible? I think that many colleagues and many friends succeed to do this all the day.
Okay, just a minute, doctor.
Even Dr. Shamsul Hoda was us this morning, and he was visible for us.
Yes, sir. Morning I was visible, sir.
Yes. Also, your photo now, or your represented photo, is in front of me now, but I didn't know.
No, we cannot.
Shall I leave or rejoin?
Take care that that you are joining from the link of video of.
Exactly, sir. I'm joining from the same link, sir.
Yes, from the same link.
I'm here since morning. In the meantime, I'd like to thank Sir Fadel sir and Azzam sir to invite our assignment team to give a session for our talks. So now I request our moderator, Dr. Rajat Agrawal, our Vice President, to start the session.
Okay, we can start until Mr. Abdurrahman will solve the problem with you. Yes.
Yes, sir.
Who the moderator can start from our team. First, I would like to thank you all to leave your business and share us in the first meeting with us. It is an honor and a pleasure for us and for our trainee. It is a very nice occasion for myself, and looking forward for many cooperation, inshallah. I didn't like to waste your time first. I need to talk with you many minutes, but I will delay this for at last time. If we have time, I will talk with you, but if we haven't, later time or later on, we will meet again, inshallah. So you return. You wasn't in the flight. You was in the space. You are not in the ground, Dr. Shamsul Hoda.
Yeah, thank you, sir.
So I can start the meeting with welcoming and thanking.
Yeah, please, ma'am.
Yeah.
Request our President, Dr. Ruta, to start the meeting, ma'am.
Yeah.
Thank you.
Then I'll hand over to Rajat.
Welcome.
Rajat, Shamsul.
Okay, so shall I start?
Yes.
Yeah, please go ahead.
Okay. Good evening, everyone.
Good evening.
This is Dr. Ruta Kulkarni, President ASAMI India. On behalf of ASAMI India, first of all, I want to thank Dr. Azzam and Dr. Mohamed Fadel for allowing us and including ASAMI India in this session. And I also must thank our dynamic Joint Secretary, Dr. Shamsul Hoda, for making this happen. I welcome all the Indian faculty members in this session today and all the members on the panel. So let's start this session. And I request Dr. Ravi Chauhan, Secretary ASAMI India, to introduce today's faculty members. Over to you,
Thank
Ravi.
you, ma'am. Thank you, ma'am.
Thank you.
Well, ASAMI India is really feeling
And as
privileged.
Dr. Fadel said, we are really looking forward to many more such combined programs.
Yeah, definitely.
Sure.
Definitely.
Sure.
Yeah.
Thank you.
Well, thank you, ma'am. And ASAMI India really thankful for Dr. Fadel for giving us this chance of coming together. And as ma'am is saying, in coming future also, we will be together for a lot of good academic feasts. So, in order to continue further, I want to share the introduction of our ASAMI India faculty. Our first faculty is Dr. H.R. Jhunjhunwala. Well, there is no need of introduction for him. He's such a big figure.
Sure.
He's a senior orthopedic consultant at Bombay Hospital, India. He was the past president of Indian Orthopedic Association in 2015. He has served as the president of ASAMI International in 2012 to 2014. He was the past president of ASAMI India from 2000 to 2006. He was the past president of Bombay Orthopedic Society in 2010. He is the chairman of Dr. K.T. Dholakia Foundation. He is the current treasurer of ASAMI India. He has chaired numerous sessions at various national and international platforms. He has several, or I can say a lot of publications to his credit in various national as well as international journals of well repute. He has delivered numerous lectures at various national and international platforms. He has delivered many prestigious origins. He has received a lot of awards. Well, anything I would say that will be less for his personality. So, welcome Dr. Jhunjhunwala, sir. Welcome. Well, Dr. Rajat Agrawal, he will be our next speaker. He did his 6 months fellowship in Bombay Hospital, Mumbai under Professor Jhunjhunwala in 2008. Did his 1 year fellowship in Baltimore, USA under Dr. Pele and Dr. Harzenberg in 2009. He has worked as an assistant professor in BRD Government Medical College for at least 1 year in 2010 in Gorakhpur, India. Currently working in Agrawal Orthopedic Hospital and Research Institute, Gorakhpur from 2011. Served as the Secretary of ASAMI India from 2015 to 2020. Dr. Rajat has delivered a lot of lectures at various national as well as international platforms. He has a lot of publications in well-reputed index journals. He is the current Vice President of our organization, ASAMI India. Welcome, Dr. Rajat Agrawal. Dr. Jeetendra Bhatnagar. He is the Senior Orthopedic Surgeon in Ujjain, Madhya Pradesh, India. He did his Ilizarov Fellowship under Dr. Ilizarov in 1991 at Kurgan, USSR. He did his 1 year postdoctoral fellowship under Dr. Pele and Dr. Harzenberg in USA. Did 1 month fellowship under Dr. Kadagni and Dr. Catenio. He was the IMA Ujjain president in 2016 and 17 and awarded the National Best Prize Branch Award for outstanding work in Ujjain, India. He has received several publications to his credit and delivered lectures at various national and international platforms. He is the member of ASAMI India Working Committee at present. Welcome, sir. Well, our next speaker will be Dr. Cherian Kuvoor. Dr. Kuvoor is a senior Ilizarov surgeon with more than 25 years of experience in treating bone defects and limb deformities. He has publications of the above topics in high impact factor journals and is a faculty at national and international forums on Ilizarov. He is a member of ASAMI India since its inception. At present, he is an executive committee member of ASAMI India. So this was the introduction of our eminent faculty. Now, without wasting time, I want to move further and invite Dr. Rajat Agrawal, our Vice President, to further moderate the session. Dr. Agrawal, please, sir.
Thank you, Ravi. And first of all, I would like to thank the organizers for giving ASAMI India an opportunity to deliver the lectures and have been given a session. It's a great privilege to collaborate internationally with speakers from different countries and share the views and the methodology, what's going on in which country. So to start the session, First of all, I would like to invite our first speaker, Professor H.R. Jhunjhunwala, on his talk on LRS in different situations. So, Professor Jhunjhunwala, please to start his first talk.
Okay, ये लगा ओके
Oh, my dear, the most fantastic, most fantastic,
very nice to see you here.
the most fantastic event to see you.
Yeah, very nice to see you.
Just 2 years only we didn't meet.
Wonderful, wonderful. It is wonderful. Instead of Cairo, I am seeing you here in Bombay.
Thank you. Welcome.
Thank you very much, Dr. Agrawal and Dr. Ravi Chauhan to introduce me, and I'm going to talk about LRS. What is LRS? It is a limb reconstruction system. Next, the indications for the LRS is you can do limb lengthening, you can use as an external fixator for open fractures, you can use infected non-unions, you can use in severely comminuted closed fractures so that you can maintain the length, and juxta-articular fractures very commonly used by LRS. Sometimes you have to do orthodesis, or you can use external fixator as a to fix up the osteotomies. This external fixator is a stable, simple, adjustable geometry, comprehensive, lightweight, inexpensive, and easy to handle. What is LRS? LRS is a rail system. You can see here this is a rail, and over that there are compartments. You can put 2 or 3 or 4, whatever you like. These are the straight compartments, and you can use sometimes you require little oblique one. So this compartment is the oblique one. And sorry. And most importantly, tapered shunt screws. They are 6 millimeter in diameter, and it is tapered. So you have to be very careful when you pass this end to the opposite cortex. You cannot take it back. So you must put one thread of the shunt screw or to the after the opposite cortex. So then you should stop it there and don't take it back. If you take it back, it becomes loose and unstable. So never do that. So you have to be very particular. Go on seeing under the C-arm that the tapered screw has reached to the opposite cortex and just gone one thread ahead. We have used LRS for about 100 patients last 7 years in Bombay Hospital. Males were 80 and females were 20. Infected cases were 72 and non-infected cases were 28. We used LRS in 44 cases of femur, 54 cases of tibia, and 4 cases of humerus. Non-infected cases 28, infected cases 72. अरे सॉरी यार क्या हुआ अरे महादेव we have used femur, in 44 cases, in tibia in 52 cases, and humerus in 4 cases. Indications for use of LRS in our series was orthodesis of the joints in 4 cases to achieve compression and stability of the fracture site at 54 cases and limb lengthening in 8 cases. For stability of the fracture and bone transportation after corticotomy in cases of infected non-unions which have bone loss in 34 cases. Here, this is an infected case. You excise the whole infected portion of the bone, create a good amount of gap, and do the osteotomy at the higher level and transport the portion of the bone down till it comes to the opposite cortex. So bone transportation 34, lengthening 9, orthodesis 4, stabilization and compression in 54 cases. So I'm going to show some of the cases, very interesting cases these are. This is a 13-year female with compound grade 3C fracture tibia fibula with neurovascular insufficiency. After vascular repair and multiple debridements, plating was done outside. When this patient presented to us, it was infected gap non-union. There were scars and sinuses, plate was exposed, and there was sensory deficit. Okay. Oh, why is it not moving? Sorry.
Sir, you can use arrow keys.
So what we did, we removed the plate and thorough debridement was done. We put bone grafts, distal corticotomy for transportation, and LRS fixator. You can see here the LRS is fixed. There was a gap, nice gap created about 4 centimeter, and these are the cancellous screws of the LRS. This is for transportation. Screws for and there was a corticotomy here. I'm sorry. Not moving.
Sir, use the arrow key on the down side. Yeah.
Put the arrow where?
Sir, on the lower side. You must be having
Put the keyboard arrow keys, sir. The keyboard arrow keys. Right and left.
Take the arrow out.
No. Please use the keyboard.
On the laptop keyboard.
Right and left keyboard keys on the laptop, sir. Not on the mouse, sir.
Sir, on the right side of the laptop, in the keyboard, there are keys.
We are done. We had done bone grafting in the gap area, so that it will form to help the callus formation there. And we are given proper antibiotics so that the wound can heal up. Sorry. Bone transplantation done and union achieved. Infection was controlled by antibiotics and debridement of proper. You can see here the bone is healed up very well, and very nice bone formation. This is a second case. 50-year-old man, somebody did nailing, but there was comminution, and therefore the fracture collapsed, and he developed 7 centimeter shortening. So I put LRS on that and distracted slowly till 7 centimeter gap is completed, and you can see here the good callus formation and the fracture united in proper position with this. 1 year, 2 months it took for the distraction and osteogenesis of the bone grafting. We did bone grafting also for that, so that the femur can heal up faster, and it healed up very well. अरे arrow किधर रखने का है?
So the arrows on the laptop keyboard. On the laptop keyboard, the physical arrow. Yeah.
This is a third case. This fellow, अरे ये arrow किधर रखने का यार, change करते थे.
आप ये बात इन बताएं.
हाँ, but arrow किधर?
बस.
This is a compound grade 3B lower 1/4 tibia fibula with partial bone loss. So operated in another hospital with intramedullary nail. So you can see here the nail. If fracture did not heal in 3 months' time, so the surgeon did dynamization and made him walk. But still, after 1.5 years of persistent non-union, despite of all measures taken for bone union by previous surgeon, he has done dynamization, he has done bone grafting, he has done nailing properly, and still the fracture went into non-union. So, when the patient came to me, I did the excision of avascular sclerotic ends. Here, avascular sclerotic ends, made a gap, did the osteotomy here, and transported this fragment till you get a proper docking. And this is the clinical picture, and this is the union achieved and limb length restored. So one has to see whether there is a sclerotic bone at the fracture site, and if there is a sclerotic bone, the union will not occur. So watch for the sclerotic bone if it is more than 1 year old. Oh, again, same problem.
Use the physical arrow key, extreme right on the bottom, sir. The extreme right arrow key.
Where is the arrow should
on
be?
The, on the laptop, sir. On the laptop, physical keys, sir. Laptop or PC. On the PC, the physical keys. You have arrow keys down right.
On right. Nah, yeah. Okay, this is a infected TKR. Orthodosis was done with the help of LRS. You could go give a very good compression with the LRS so that the orthodosis occurs very fast in septic arthritis of the knee. another case of subtaloid arthritis, and you require a subtaloid fusion. So you put your LRS, one pin in the calcaneum, one pin in the tibia, and do good compression so that you can get a subtaloid arthritis union very fast. This is a long-standing infected non-union, and here it is used as a compression device. This is another case having a lady of 20 years, non-union. In the childhood, she had a chronic osteomyelitis and the pus was coming up for 20 years. It was debrided. The plate which was broken was removed. The was completely debrided, waited for antibiotics, and we waited for a few days till the pus stops. And once the pus formation stopped, we put the LRS and a compression slowly, and you can see that on the right side, the femur fracture, which was very bad last 20 years, is the LRS, we could achieve a good union and good result. Thank you very much. Thank you. Any questions?
May I ask one question? May I ask a question?
Sir, Dr. Fadel, please go ahead.
You mentioned a very nice conditions for LRS. So I need one of the bad or the worst LRS complications you met.
Jhunjhunwala sir.
Yes.
Dr. Fadel is asking a question.
Yes.
The worst case in LRS, do you met it or no?
Sorry?
Do you have some complications from LRS?
Sir, Dr. Fadel is asking, do you face any complications? And if any, please.
Yes, because there are complications. Sometimes you can get bending if there is too much force for lengthening and all. The pins can bend or pins can become loose. Pins, and if they become loose, they can get infected. So nowadays you can use a hydroxyapatite coated pins, which they don't get loose, and there is less chance of infection.
Sir, can you unshare it? Unshare your screen. So on the lower side of the laptop, there is a
you can request the IT support to unshare.
These are the problems with the LRS. Pin loosening, pin track infection, bending of the pins, monolateral fixator, hence you cannot take full weight. While walking, you have to take very partial weight. Like Ilizaro, you can take full weight. And because the compartment are limited span, so you have to be very careful that the bone should be at least 2 inches long present at the upper end, proximal end or distal end, where you can put your LRS. Thank you.
Jhunjhunwala sir, I am having one question. Sir.
Yes, yes.
Sir, in one of the case you have shown the knee arthrodesis by using rail fixator.
Knee arthrodesis, there was infected TKR, which is supposed to be for the knee arthrodesis.
My question is how you maintain the flexion at the knee, or you just fix it in the full extension? You just arthrodese in full extension, or if you go for some flexion, then how you maintain the flexion?
No, in extension.
In full extension?
No flexion, extension, so that you can get a good compression. In extension, you can get a good compression and the patient can walk. There is always little shortening when you do the arthrodesis of the knee, and that shortening helps to propagate your leg forward.
Okay, sir. Thank you, sir.
Thank you.
Rajat sir, we cannot hear you, sir. Rajat sir, your voice is not clear.
Dr. Shamsul.
Yeah.
Can you ask the IT person to unshare the screen?
Yeah, please, IT support, please unshare Dr. Jhunjhunwala's screen. Request to IT support. Rajat sir, your voice is not clear. Sir, please remove the microphone if you have any. Rajat sir.
Sir عبد الرحمن ممكن تساعدنا في انك تعمل unshare للدكتور for Dr. Jhunjhunwala? Can you do this?
Okay, just a minute.
I think you can cut off and return him again, I think. Okay, very nice.
Rajat sir, we cannot hear you.
Sir.
Rajat sir, your voice is not coming. I think there must be some issue with your microphone. Rajat sir.
Rajat sir, your voice is not clear.
Now I think it's good.
I think he is also not able to listen to us.
You can start again, I think.
Next talk.
Yes. Now you can start.
Rajat sir, are you getting us? Actually, your voice is not coming to us. Your voice is not coming.
Something wrong with the microphone.
You can request next faculty.
Dr. Shamsul, we can move ahead with the next faculty, please.
Yeah, there is echo also. There is a lot of echo coming.
So our next talk is by Dr. Jeetendra Bhatnagar, sir. His talk is on hip reconstruction without head excision by laser.
Jeetendra sir, please share your screen.
Who is going to have next? Jeetendra, you are going to talk?
I think there is some problem with the connection of. So, Dr. Shamsul, by that time we can move ahead with the Dr. Cherry's talk.
Yeah. Cherry sir, you are here?
I'm here.
Dr. Cherry is here. In the meanwhile,
can you hear me?
In the meanwhile, we can continue with the Dr. Jeetendra after this talk.
Yeah, can you hear me?
Yeah, Cherry sir, please go ahead.
Okay, then I'll share my screen.
Yeah, please.
Can you see?
Yeah, sir.
Yes, it's going well. Yes.
Put it on slide mode and go ahead, sir.
Yeah. Yes. Good afternoon and or rather good evening in India and good afternoon in Cairo.
Yes, you're right.
Okay. Yeah, I'm going to talk about Blount's disease, one of my favorite the topics. I always love to do these cases. And it's giving an introduction. It is a disorder of the proximal tibial growth plate medially, causing progressive varus knee malalignment in children and adolescents. Usually it is associated with early onset walking, obesity, and African American children are more prone. And bilateral cases are more common than the unilateral cases. Now, there are a lot of synonyms, but I think the most common synonym that is used is the infantile tibia vara. All the others have been used, but not so popular. Infantile tibial vara is the most common synonym that has been used. Now, clinical features are similar to very severe physiological genu varum. Many of these children are obese, but not all of them. And there is often a lateral thrust on walking. That is all the clinical features that should lead you to a suspicion of a Blount's disease. Now, what are the radiological features that identify a Blount's disease? One is an abrupt varus angulation at the metaphyseal-epiphyseal junction. 1 minute, let me just... Yeah, sorry. One is the abrupt varus angulation at the epiphyseal-metaphyseal junction. Second is widened irregular metaphyseal line medially and medially sloped epiphysis and prominent beaking of the medial metaphysis and lateral subluxation of the tibia. Now, all these features may not be there in a case, but medial sloping of the physis and widened irregular physeal line medially should lead you to think that it could be a case of Blount's disease. Now, differential diagnosis is severe physiological genu varum, but then radiological features identified from distinguish it from Blount's. Of course, rickets is another differential diagnosis, but X-ray features and the vitamin D levels and serum alkaline phosphatase levels should confirm the diagnosis. Skeletal dysplasias are not too difficult to identify from Blount's. Multiple bone involvement and a lot of other systemic involvement also will be there. Post-infectious, yes, sometimes some of them may look like bones, but not always. Now, Langenskild has defined 6 stages, stage 1 to 6. Stage 1 and 2, complete restoration is common if treated early. Stage 2, 3 and 4, restoration is possible. Stage 5 and 6 are the severe ones. But the catch in the Langenskild classification is it has been described for whites, especially the Scandinavian whites, and it's not very accurate for the non-whites. Staging can occur stages can occur earlier in non-whites. It can skip a stage and progress to 6 in non-whites, and worse in black females. And unfortunately, no data on the Indian population. So Langenskild classification probably is not a very applicable classification for non-Scandinavian people, but that is the only thing we have got now, right now. So treatment depends on the stage and age. Stage 1 and stage 2 at 2 to 3 years, you can go conservative, less than 3 years of age, and unilateral cases, about 94% success rate is there. I don't have a great deal of experience. These pictures are from my professor, Dr. Benjamin Joseph. But failures occur with conservative treatment in very obese children, severe ligamentous laxity, late initiation of treatment, that is more than 3 years of age, and bilateral cases have a 70% failure. This is one of his cases which has been treated conservatively, and it's got corrected to almost normal. Now the question is splinting. Is 24 hours better, nighttime or daytime better? Now the publication by Rani in JPO in 1998, whether you do 24 hours or nighttime only or daytime only, it gives the same result. So I would prefer to use it while walking, and it has been quite fruitful. Now stage 1 and 2, again, more than 3 years, you need to do a metaphyseal corrective osteotomy and fixation, either acute or gradual, external fixation or internal fixation as your choice, and overcorrect to 5 to 6 degree of valgus. Now this is a case of something between stage 2 and 3, corrected with an Elizar O-ring fixator, metaphyseal osteotomy, bilateral Elizar O-ring fixator, and that's the end result. Slight valgus is given, and that's the final X-ray. This is the gait before. That's the difference in gait. Acute corrections with POP alone I've got very limited experience. Again, these are from my Professor Benjamin Joseph. But you can, the results are equally good, provided you do it carefully. Now, stage 3, again, you need to do only a corrective osteotomy in the metaphysis. But delaying surgery, there is a high chance of slipping to the next stages, and the recurrence rates will be higher. This is a stage 3 case. An arthrogram was done to make sure that there is no intra-articular depression, and a metaphyseal osteotomy and correction. That is a full correction that is achieved in the last X-ray. Similarly, acute correction also can be done, and the results are also quite good. Stage 4 and 5, they are more serious. Facial arrest has already occurred, although not seen. Now, from here onwards, it is important to distinguish between two deformities. That is metaphyseal deformity and epiphyseal deformity, which I mean is a medial epiphyseal deformity, and in other words, intra-articular depression. And treatment must be individualized. So that's the epiphyseal deformity and metaphyseal deformity. You need to appreciate that there are two types of deformity, two levels of deformities. So younger than 7 years, medial epiphyseal is an interposition material with metaphyseal plus or minus metaphyseal osteotomy. I'm not much experienced with medial epiphyseal because most of my cases have been more than 7 years old. I've been doing intra-articular osteotomy and elevation as stage 1. This is a girl with stage 4. You can see the epiphyseal medial articular depression. Arthrogram, you can appreciate the depression. So first stage, intra-articular osteotomy, elevation, fibular strut grafts. And now once that is healed up, you can assess the metaphyseal deformity properly. I prefer to do it after 8 to 12 weeks. Illusory frame to correct the metaphyseal deformity, because that is one thing that is under my control. That is a patient after union walking full weight bearing with the illusory frame. And that is the end result. Now, stage 6, this is the worst. It occurs in older children. Medial bony bridge and epiphyseal closure has already occurred. And as long as the growth is present, the deformity is progressive. Now, here there are definitely two deformities, intra-articular and extra-articular. So it needs two osteotomies, intra-articular and metaphyseal osteotomy. You may do it in one stage or two stages, but two osteotomies have to be done. Now, this is an 11-year-old girl, previously operated at 7 years of age, must have been stage 4 or 5, but only metaphyseal osteotomy was done. This is the clinical picture, and that is the X-ray. That is how she is walking. Now, if you notice, there is an internal rotation gait also on the right side and both the sides, but more so on the right. Now, that is the intra-articular depression on the medial side. And the metaphyseal varus, you cannot assess with the intra-articular depression the amount of metaphyseal varus. And these are the measurements that we have got. But again, they are not accurate with the intra-articular depression. No, it needs a lot of planning. Now, whether CT scan is needed or not, it's a big question. But most of the deformity is very obvious on the X-rays. CT scan is, I don't think it is really needed, but somebody has taken a CT scan. Now, anyway, coming to the treatment, step 1, intra-articular correction. That is intra-articular osteotomy, elevation, fixation with screws, and fibular strut grafting. So once the intra-articular component is taken care of, you can assess the metaphyseal deformity. So on the left is an oblique plane deformity. On the right is just a pure varus deformity. So the frame made accordingly, pre-made frame fitted. That is a correction. Now, there was an internal rotation deformity, so we had to do a rotational correction. You can see the amount of translation that has occurred, nearly 100% translation with good region drift. Now, that is a deformity that is fully corrected. That is a X-rays. Now this is after the removal of the frame. Now this is pre-op and end result correction. That is 6 years later. The correction is still maintained. The X-rays, and you can see as on the right side, the rotational, the translation deformity is completely remodeled. And that is the full correction. That is the result after 6 years. Now, can we do an acute correction? Yes, certainly, either with external fixation or internal fixation. But the problem with internal fixation is when you have corrected, you can't do further adjustments. You may undercorrect or overcorrect. And there is always a slight danger of compartment syndrome and infection with internal fixation, which can be disastrous. RAB osteotomy is a wonderful osteotomy, especially in younger children. It is a single plane oblique cut, allows simultaneous correction of varus and internal rotation, and does also permit postoperative cast wedging if necessary to obtain appropriate further correction. But sometimes in younger children, you may have to do it under anesthesia. With the ring fixator, the advantage is you can just, the correction is in your control. Now, guided growth, I have very limited experience with it. There are limitations to it. Probably you can correct mild or moderate deformities, varus less than 15 degrees, MPTA more than 75 degrees, mechanical axis deviation less than 60 millimeters. Oh, sorry, yeah, at least 2 years of growth remaining, and limited, the limb-link discrepancy should not be more than 1 centimeter. And the patient, heavier patients or more BMI or heavy patients have a higher rate of implant failure. So these are the limitations of guided growth, but it's still worthwhile in these. If the indications are met, guided growth is worthwhile. MRI, not much of use. It gives you an idea of medial growth plate status. Medial articular depression, you don't need an MRI because it can be seen very well with an arthrogram. Again, you need the assistance of a radiologist to interpret the MRI. Again, small children, you need sedation and anesthesia to take an MRI. So in summarizing, especially after stage 3, consider the possibility of intra-articular deformity. An arthrogram is invaluable in defining intra-articular deformity. After correction of the intra-articular deformity, assess the location and magnitude of the metaphyseal deformity. Acute or gradual correction, internal or external fixation as the choice of the surgeon. Acute correction, keep in mind compartment syndrome, overcorrection or undercorrection. Now, few messages are there. Don't be terrified of the deformity. Some grotesque deformities you may see. Keep the patellar straight and your deformity becomes clear. View good clinical examination. View from front, behind and side. And gait X-ray, observe the gait. Proper X-rays including stress X-rays. Proper malalignment test. Locate the cora or coras. CT or MRI as needed. Decide whether you're going to do an acute correction or a gradual correction or internal fixation or external fixation. And select your implant, whatever you're comfortable with. Spend time with the patient, discuss pros and cons. Thank you.
Thank you, Dr. Cherian, for your wonderful talk.
Can I ask a question?
Yes, Ruta.
Yeah, Jerry, it was a fantastic overview of Blount's. I wanted to know about the rate of recurrence, especially after grade 3. In how many cases did you have recurrence of deformity, especially the intra-articular deformity?
No, intra-articular deformities, I've done about 10 cases. The recurrence of the intra-articular deformity I've had in 2 cases, but metaphyseal deformity I had about in 3 cases.
So out of 6, 5 recurred, you mean to?
Yeah, it did recur.
Yeah. So how did you manage? Did you redo?
I had to redo. I had to redo. Some of them are still under follow-up. Probably next time I would be able to show that.
Yeah, because that's the problem with Blount's, especially in advanced stages, the recurrence. Yes. And one more I wanted to ask. Did you ever try RABs like osteotomy with Elizarov to correct the angulation and rotation and translation, everything in one go?
No, with the Elizarov, you mean an acute correction and fixation with an Elizarov frame?
Yes.
Yeah, I've not tried. I've tried a RAB osteotomy alone, but not combination with Ilizarov. Because Ilizarov is used only for acute correction.
Cherry, sir.
Thanks.
Yes.
Sir, what are your indications for RABS osteotomy?
RAB osteotomy, maybe I would prefer to do it in stage 1 or 2, where there is no intra-articular deformity.
Okay.
If there is an intra-articular deformity, I wouldn't really, and younger children, not older children. I'm not, to be honest, I've not had much experience with it. I've done only about 2 or 3.
Okay. Is there any other question? So, Dr. Rajat?
Yeah.
Yes, sir, we can.
Okay. Thank you, Dr. Cherian. A wonderful talk on Lowndes disease. And next, I will invite Dr. Jeetendra Bhatnagar on his talk on hip reconstruction without head excision by Ilizarov. A very interesting talk. Dr. Jeetendra Bhatnagar.
Well, I'm trying my level best, but I don't know why my screen is not getting shared.
Jitendra sir, can you mail your PPT to me? I will share it from my side.
Okay, I'll do that.
Just mail it to me.
Jito, put it in Google Drive and share it.
By that time, we can have Dr. Shamsul's talk.
Yeah. Meanwhile, I invite Dr. Shamsul Huda on his talk on the very important topic, which is to be dealt by every orthopedic surgeon of the world. Dr. Shamsul Huda on his talk on open fractures by Ilizarov. So I invite Dr. Huda.
Yeah, thank you, sir. I thanks again Fadel sir and Amar sir and LRS.PD to give chance to ASAMI India for a wonderful platform. My slide is visible, Dr. Ravi?
Yes.
Please go ahead. Dr. Shamsul, please go ahead.
Yeah, thank you. So today I'm going to talk on Ilizarov in open fractures. So normally, we usually get open fractures in terms of high velocity trauma, RTA, crush injuries, accidents like this. So it's very difficult to decide whether the limbs will survive or not, whether we have to go for amputation or it can be salvaged. So if you have a sound knowledge of Ilizarov and if the distal universal pulse is normal, intact, we can definitely save these limbs with Ilizarov surgery. So in any compound high velocity trauma, the usual causes velocity trauma or RTA associated problems may be shock, blood loss, head injury, visceral maxillofacial injury. We need to care for the ICU and multidisciplinary support. We have to see for hemostasis and hemodynamics. And then if the patient is surviving, then we go to the limb, whether it is a comminuted compound fracture, neurovascular injury, compartment syndrome, bone soft tissue loss, degloved bone. Is it at risk of amputation? If there is an infection, we have to care for weight, elevate, slab and fix, and then we go to plan for treatment. So the diagnostic protocol is first we go for X-rays, for grading of fracture, plan of treatment, evaluation of healing, and then we go to see if there are CT scans and CT angio to see if there is a head injury or associated visceral injuries. And we can also go for MRI and USG to check associated injuries. So planning and evaluation is based on Dr. Anderson's classification for compound fractures. If it is type 1, one is less than 1 centimeter, internal flexion is ideal. We usually do nail or plate. If it is type 2, wound is greater than 1 centimeter without extensive soft tissue involvement, we can go for X-fix, skin graft, or if Ilizarov becomes an option here. In type 3, open fracture, soft tissue, muscle injury, 3A, when there is soft tissue coverage, despite soft tissue laceration, then X-fix and skin graft can be done. Ilizarov is a better option. In type 3B, when there is extensive soft tissue loss, periosteal stripping, bone exposed, bone loss, contamination is there, Ilizarov then becomes a true indication. Loose bone can be removed, bone transport can be done. In type 3C, we have to first see if the vessels are intact, if the arterial injury can be done, repaired, or if the limb survives. Well and good, we can do for Ilizarov. But being an Ilizarov surgeon, I usually do Ilizarov in all the compound open fractures. So we follow all this chart to classify these usual charts. Clinically, the same thing we can see here. If it is in grade 1, 2, or 3, to decide whether we can go for internal fixation or external fixation with L0, H-fix, LRS, or anything else. So the indications for L0 in open fracture becomes when there is bone loss and exposed bone, compound bad soft tissue coverage, infection with soft tissue and bone, and there is comminution, contraindications, and if there is polytrauma, head injury, multi-organ injury, neurovascular injury, or if there is any bad articular injury, whether either it is relative, we can also do L0 articular injuries also. Advantage of L0 over other fixations is that, like LRS, is that it gives circumferential support. Next post-op day, full patient can walk, full weight bearing, full range of motion can be there. The spring action of wires, the law of tension and stress of wire, it enhances healing and regeneration. Soft tissue procedures can be done like skin graft, flap, and back over L0. There's no joint stiffness if applied well with use of hinges and joints. It is a modular implant. All the displacement, angulation, compression, distraction can be corrected gradually. If there is both, can be done. Patient can be trained for self-dressing, transportation. Disadvantages: it is a cumbersome implant. Patient complain bad at times. Wires if not tensioned properly. Pains. It's a long duration treatment. Can go from 4 months to 2 years. Pin track infection is very common if not handled properly. So proper training is very important. Skin wound dressing becomes difficult if the patient goes home for a long period. And in case this rail fracture of LRS, it is lightweight, easy to handle, no circumferential support, weight bearing partial only. So what we need to be prepared with a pre-workout for trauma care. We need to have a trauma care, a critical care unit. Always in duty, we keep X-fix set, rail fixator set, L0 box, nail plate backup. Backup of plastic surgeon, neurovascular surgeon, vascular surgeon, very important. We have to arrange BT as needed. So the basic principles of L0 fixation and open fracture is we first wait, elevate, span, we put a slab or X-fix, we debride, we do neurovascular monitoring for a few days, 5 to 7 days. If to see just if the limb is surviving or not, if there is no distal pulse, if there is gangrene, we have to amputate. But if there is distal pulse there, the limb is warm, if there is no soft tissue or bone, we can still go to salvage the limb. We can fix with L0. If there is bone transport, we can do corticotomy, transport, and there is soft tissue loss, we can do its procedures. We must have a sound knowledge of corticotomy and bone transport before doing these case surgeries. I always keep my L0 or armamentarium in my OT, whether it's a nailing or plating, I always keep it there when I have to decide for this. All the young surgeons must have a sound knowledge of the neurovascular status, where to apply the pin, the safe locations, safe areas, in the upper limb, the arm, forearm, thigh, and the tibia. These are very important knowledge before moving ahead for any L0 surgery. These are the usual fixation procedures or reduction procedures for any L0 cases in lower limb or the upper limb. These are the various configuration we can use. If you know this, we can apply L0 anywhere in the body, in the limbs. So let's start with the few cases. This is a case of open fracture humerus with exposed bone. The pus was coming, so we cannot apply a plate in this case. If we apply an X-fix, the joint will become stiff. So we went to reduce the fracture, do a thorough debridement, and applied laser in this case. So I reduced all the fracture fragments with olive wires. You can see it is well reduced. And over it, I applied laser fixator. After fixation, all the flexion, extension, all the movements were quite normal. And with this, patient was doing all the movements. We did the active physiotherapy. It healed very well in around 4 months. The ring was removed. You can see it is full flexion. There's no wound, healing very well. If you had applied L0, if you had X-fix, we could not have given this result. Another similar case of distal and humerus fracture, compound infected. Applied L0, healed very well with this. Another case of forearm fracture where a compartment was there. I had to do fasciotomy. So the bone was exposed. We cannot apply a nail or a plate here. So I applied L0 here in this case. And once the wound was healed, I applied a skin graft on this case. And with this, bone is healing very well. And start to remove. Another case, bone transport of proximal tibia with bone loss. You can see it's a bad comminuted fracture. Exposed bone was removed in this case. Patient was in bed. the dead bone was removed, Elizero was applied, bone transport was done in this case. Wound healed with time very well. There's no need of skin graft when you apply Elizero in most of the cases. Bone transport was done, and you can see with time the ring was removed, the bone healed very well. Now the patient is on a brace, the slab has been removed. Another case of distal femur infected open wound, Elizero was applied, healed very well with Elizero. We can always do full weight bearing walking all the patients if apply Elizero. So walking is the basic formula every patient has to do. Another similar cases of compound femur fracture and tibia fracture, when the femur was fixed nail and it was applied with fixed with Elizero since the bone was exposed. This is a case of proximal tibia fracture when there was a compartment and the bone was fasciotomy was done. Bone was exposed, so you can apply a plate and this rings with and gave a compression with olive wires, and it healed very well. Patient walked next day. And when the wound was healed, skin graft was done, and it was removed in 3 months only. These are another simple cases of distal tibia fractures compound healed with Elizero. This is another very interesting case of a very bad crush wound injury in a young girl of 17 years. Tractor was run over in this case. You can see the very bad lacerated wound in this case, pelvis. Patient and amputation was done at knee level. Patient was in extreme depression and was suicidal. So we consoled the patient. We tried well and skin applied. Temporarily, excess was applied in this case, but there was infection. Wound healed well, but there was no union because a temporary tense was also applied in this case. And the excess was removed and rail was applied in this case. Still, wound didn't united well. Then I removed the tense, removed LRS, applied Elizero, did 3 or 4 cycles of piano accordion method. It healed very well. Now the rings have been removed. It was good luck for the patient that she was married. Another case of exposed bone, in this case with a knee contracture. Elizero ring was applied for bone transport as well as knee contracture correction. You can see the bone has been healed very well. The loose bone has been removed. So bone transport is a very good option, and compound we applied the once again. So flap can be done on Elizero, and also in cases, in the rare cases, we can do WAC also in exposed open. So they are very important for all the young surgeons. First post-op day or second post-op day walk. Counseling is very important. Physiotherapy is very important. Joint mobilization every day. Daily dressing. Train well the patient for the dressing. Follow up exercise very regular. It's a modular implant. So the take-home message in this case, open excellent device for management, proper follow-up done. It can be a wonderful device. Use a primary device. It works as a magic. Other options available and can be decided on table. Good knowledge and experience of Elizero is needed. It is a modular implant and can be adjusted post-op as required. Soft tissue heal well with Elizero on. Soft tissue flap, SSG back, is friendly with Elizero. Joint stiffness, interarticular fracture is not a problem to handle well. Post-op rehab is very important. So if you work well, if you do a good rehab, either in upper limb or lower limb, if you do a good surgery, all the bones can be saved, not from the wood, of the limb, of the joints. Patient can do all his activities at home. So I always keep this armamentarium, this magical box with me in my OT, whether it is any OT. So the hashtag for today is Hope is Life, Elizero Saving Limbs. These are my mentors who have taught me Elizero. With guidance and help of them, I have come to this place. Thank you. Thanks a lot.
Thank you, Dr. Shamsul. Wonderful talk. This talk has to be seen by every orthopedic surgeon, especially the young surgeons who have to do the open fractures. And now I think Dr. Jeetendra is ready with his talk on.
I'm trying. I don't know why my screen is not getting shared.
Ravi, can you?
Have you mailed your PPT?
I have not received your mail, sir.
Which mail?
Have you mailed me your PPT?
No, I have not mailed you. How can I share this?
Can I ask the IT to guide you, Dr. Jeetendra?
Yeah.
Abdurrahman, can you help us?
What do you want?
Yes, you have a look.
معك يا دكتور بس ايه المشكلة؟
What is the problem that you couldn't share the screen?
Share my screen, you know.
Okay, you have the presentation. خش يا دكتور عبد الرحمن يا مستر عبد الرحمن. هو مش عارف يعمل لها شير. Please first open the presentation and keep the screen as you present it anywhere. It's okay. Then move the cursor down to the bottom of the screen. You will find a row of tools.
Hold on, I got it. Probably I will do it.
One of the rules of the tools is green.
Green?
Yes, press on it. Click on it. It will carry you for your screen.
Then, sir, are you using Mac or just normal Windows?
Sir, have you using
iPad? I'm using iPad.
You are using iPad?
Yeah.
Is your presentation is the keynote or what?
It is in keynote.
It's from the Google Slides.
Google Slides. You can just import.
Sir, first download it and save it in the files, or just open it first.
So download and open with Keynote. Open it with Keynote, sir. First.
Okay, can I do it by Keynote?
Yes, sir. Please open it with Keynote. Please open the slide with Keynote. Then you can share from iPad directly. Or you can simply mail to Ravi or me or to IT. You can share the Google Slide link to us. Sir, you can share the Google Slide link.
It's better to download from the Google, sir. It's better to download from the Google.
So if you have the share online in Google Slides, you can simply share the link with us. Either me or Ravi. We'll do it from here. Or simply open in Keynote. You can do it from there, sir.
Jiten sir.
Yeah, sir.
Are you just have you clicked on the share on your iPad?
Yeah, I did that.
Or after clicking on the share, there is a panel which is falling down.
Yeah, that has already come, and probably it's connecting, I think.
On that panel, there is a Google Drive link. Are you sharing with that?
That I did. Now Google Drive wanted my email ID and password. I did that also.
So do one thing. Just download the PPT. Just download the PPT and open it. Just download the PPT and open it on your iPad.
Probably it's connecting to Google Drive.
Hey, are you able to download it?
there is one window which came that says share. 8 people or group.
Just people kar dijiye. And just share the link. Share the link with me on my WhatsApp.
Yeah. You will see Zoom. Click on it, sir. When you click see Zoom, click on it. So when you share the screen on iPad, what you're seeing, sir? Please tell me. Sir, when you're clicking share screen, what screen you are seeing?
Actually, Dr. Shamsul, the problem is कि he must be seeing the जैसे हम iPad के ऊपर click करते हैं ना, and then definitely there is a panel which fall down.
Yeah.
And after opening that panel, he must be going to the Google Drive, but Google Drive is asking the password and something like that.
Okay.
Problem is कि PPT is in the Google Drive.
You can simply link the share the link of PPT.
Yeah, but for that one thing need to do na. On the iPad he has to open the WhatsApp. That's a different glitch.
No, on mail. Just share the link on mail.
Definitely. By mail he can do that. But for that he need to copy from there na link. All technicality hold.
Yeah.
It's very technical, I think.
Yeah, Jeetendra sir, can you hear me, sir? Jeetendra sir, can you hear me?
Yeah.
Sir, is your PPT opened in the background?
You want me to open it in my iPad?
Jeetendra.
Sir,
Yeah.
just a minute. Please go to share screen. You will see Zoom. Share to Zoom. Click on share screen. What screen you are seeing? Tell me, sir. Just share screen will tell you, sir. Because I have my iPad open sideways only right now.
What do you want me to do?
Sir, share your screen. Just share your screen.
There is a share content. I did that. Then
share screen, sir. Share screen.
Pardon?
Share screen.
That is what I'm doing.
Zoom. What you are showing after that, sir? After that, what
there is a box which came which says screen photo, iCloud Drive, Dropbox, Microsoft OneDrive, Microsoft SharePoints, Google Drive.
Just click on. Is there Zoom? Can you see Zoom?
No, I can't see Zoom. Zoom out. Yeah.
Just click on Zoom and start broadcast, sir. Just click on Zoom, start broadcast. Have you done, sir? Please do it. I'll tell you, sir. Please click share screen, click on Zoom. I'll see on this screen. Just click share screen, sir, right now. We'll see on this share screen. And click on Zoom.
Where is Zoom? Okay, Zoom.
Yeah. Share the screen.
They are connected to Zoom Google network via center of church. That is what is coming.
I think there is Shamsul. So last time you shared the screen, we could share your screen share. Please go that way, sir. I'll guide you then. Just last time you shared your screen, I saw your screen share. We could see your screen. After you share a screen, you just have to minimize and open the PPT. I think sir has to share the link.
Yeah, that's the only option actually.
Let me call sir. Let me call him. In the meantime, if you have any case for discussion to share, ma'am, Ravi, or anybody, please, you can continue. Ma'am?
I need to open my laptop.
Cherian sir, Ruta ma'am, if you have any case for discussion, we can do in the meantime.
Not prepared for that.
Not prepared actually, not really.
Okay. No. Let me call sir. is not picking phone. So, sir, can we do it for the next session?
Yes, I think we can't wait.
Yeah. Ma'am, can we request sir to
It's time of
next session?
other people.
I think Dr. Shamsul.
I think you better ask someone else to continue, okay?
No, I think we're done.
Sir, I think sir, actually we are done with the all lectures.
Okay, so please, probably I may not be able to share. I think this is a question.
No, sure, sir. We can do it next session. Sir.
Dr. Shamsul, I think we should conclude at least.
Yeah.
Fadel sir has asked to do next Friday a complete Assam, Egypt, Arab and Assam, India session. So, Ruta ma'am, your view and sir's view on this.
Okay, you would like to, sorry for this inconvenience, no problem at all. We are missing this lecture. We are waiting it, and I hope, inshallah, but next Friday it will be in Eid al-Adha, and I think most of our colleagues were not ready to do any activities. They are in vacation.
Yes.
If it is, and hope for you in these holidays, for you all the best of the wishes for health and safe for you and your families. So we can make an appointment again for maybe next. We will talk with you, Shamsul.
Dr. Shamsul.
Yes.
Dr. Shamsul, I think we should make it in August first week or second week. I think by that time we can have the time to prepare for some good topic lectures.
Yes, it is very nice, and we start and we will continue, inshallah.
Yeah, definitely, sir.
Yes.
Hopefully next time I will be prepared. I'm sorry for this. Next time I will be prepared.
We know that it is well prepared, but the connection and the internet is not.
I'm sorry. I'm extremely sorry for this. Next time I will be prepared with one computer engineer along with me. Okay?
No problem. We are waiting you.
Okay.
Next time, inshallah.
Thank you. Okay.
Sure. Thank you, Dr. Fadel. So, ma'am, Ruta ma'am.
Rajat can conclude. Yeah.
Yeah. Dr. Rajat and Dr. Shamsul, please conclude.
Rajat sir.
Rajat sir, are you there?
Sir, we cannot hear you, sir.
And I think all the audience must have learned a lot from the various lectures, ranging from blounds to open fractures, and by the talks by the Indian and the international delegates. So, with this note, I think we'll be continuing further with further collaborations and having much more lectures on much more varied topics. So, I thank you all for attending the session, and I hand over to Dr. Shamsul to end the session.
Thank you, Rajat sir. Thanks a lot, sir.
Thank you very much.
Thank you.
Thank you.
Yeah.
Thank you, sir.
Yeah, thank you, sir. Thanks a lot. Thanks, everybody, all the international faculty, all the panelists, all the young surgeons to attend the program. We'll do more further. Thank you. Thanks a lot, sir.
Thank you.
Thank you from Ortho TV also.
Thank you.
So, Dr. Shamsul, now we can leave.
Thank you, Mr. Abdurrahman, for your IT support, and thank you for our trainee for LRS for staying with us for now, and also for those trainee who presented for us some of their extra assignment. And thank you for our friends from ASAMI and India and Ortho TV panelists for joining us, and you give us an honor, and for those trainee who presented in front of you their work. Thank you, and meet you inshallah soon.
Thank you, Dr. Fadel. Thank you.
Goodbye.
Goodbye.
Thank you, sir. Good night, sir.